A warm welcome to everyone. Thank you all for coming to share with us our 30th anniversary celebration at the Institute for Health and Aging. I'm Wendy Max, I'm the director of IHA, and we're very proud of all that we've accomplished in these last 30 years. Today we want to share with you a number of things. We want to share, first of all, the history of how we got to where we are today. We also want to talk about some examples of the cutting-edge research that we're involved in currently. And then finally, some thoughts on key issues facing us and our faculty as we move forward, how IHA research can address some of these important issues facing our society today. We're particularly excited to have Dr. Fernando Torres-Gil as our keynote speaker to describe the landscape in aging from his multiple perspectives. We'll hear from him later this afternoon. IHA is what in UC parlance is known as an organized research unit. I'm not sure that means anything to people outside of the UC system, but we've been an ORU now for 30 years. We were originally founded as the Aging Health Policy Center, and then a few years later, we became an organized research unit. We currently have 27 faculty, 23 additional faculty with either without salary or affiliated appointments, and over 40 staff. We conduct policy, clinical, and social behavioral research. We work with students, postdocs, and visiting scholars. We provide public service through our work with the state of California, through symposia, and through testimony. Our research over the years has focused on aging and disability, but defined very broadly and over the life course. It includes work in aging and chronic illness, including disability, health promotion, health of diverse populations, women's health, health economics, particularly related to the economics of tobacco use, and bioethics and translational genomics. So we have a pretty broad research agenda. Many important collaborations have existed over the years, and I won't go through all of them, but I do want to mention one event that, a very fortunate event that has had a particular impact on me. And that was in 1985, Dorothy Rice, who is somewhere right in the middle here. Wave, Dorothy. Dorothy Rice came to IHA as a Regents lecturer. She had just retired from the National Center for Health Statistics, where she was the director in Washington, and our founding director, Carol Estes, convinced her to come to IHA to join our faculty. I think it helped that she had 2 sons living in the Bay Area at the time, but we like to think it was just because she wanted to be with us. In addition to being a wonderful colleague and resource for the entire campus, she became one of my dearest friends, and to this day is one of my mentors. So we're delighted to have Dorothy and to have her celebrate with us today. We recently established a twice-yearly series of symposia that are open to the academic community as well as our community partners and to the public. This is the 3rd symposium that we're offering. Earlier symposia focused on the White House Conference on Aging and advanced care planning to improve community-based palliative care. So now, let's begin our program and talk about an overview of how we got to where we are today. It gives me enormous pleasure to introduce our first speaker, Dr. Carol Estes. We wouldn't be here if it weren't for Carol's vision, insights, and perseverance. Carol founded the Aging Health Policy Center, and a few years later, in 1985, took it to the next level and obtained organized research unit status, which requires that the regents of the University of California approve it. So that is no small feat. She served as our founding director from 1985 until 1999. She's also professor of sociology, served as the chair of the Department of Social and Behavioral Sciences until 1992. Carol's recognized as the founder of the field of the political economy of aging, and has been passionately devoted to improving the health and economic security of vulnerable and underserved populations, especially older people, women, and minority groups. Carol's work is focused on Social Security, Medicare, healthcare reform, and long-term care policy. She's a prolific writer of books and scientific articles, has excited countless graduate students and postdocs and gotten them involved in the work, which for Carol is really more of a calling, I think. She's also has consulted with many federal agencies. She's past president of the Gerontological Society of America, the American Society on Aging, and the Association for Gerontology in Higher Education. She's been involved in many other organizations, including several advocacy groups such as the Gray Panthers. She's received numerous awards, including membership in the Institute of Medicine and UCSF's highest honor, the Gold Medal. I could go on, but I think you'd probably rather hear from Carol herself. So let me now turn it over to Carol Estes.
Thank you so much. What an honor to be here. And I do want to make clear that I did not do this work alone. And there are two members of our community who are here now, Robert Newcomer and Charlene Harrington, who were extremely instrumental in the early development of our center, Aging Health Policy Center, and were part of the founding research group. And they deserve serious recognition and acknowledgement for what they have not only what they have continued to do in their life and mentorship and model. So I want to also acknowledge and thank the Dean of the School of Nursing, Dean Vlaha, for coming today and being here, and for Fernando Torres Hill, who is a longtime compatriot, and we used to talk about being co-conspirators with Maggie Kuhn, who founded the Gray Panthers, and so we have known each other for many decades. I want to start off by saying that when I came to UCSF in 1972, it was a propitious time because the extent to which I had had an opportunity to be educated in numerous places gave me many ideas that I brought here and then was able, with my team, our team, to put into effect. And one of the very important experiences was being at Brandeis University in the mid-60s when Social Security was expanded, when Medicare was established, when Medicaid was established, when the Older Americans Act was established. And I was living amidst everyday policy wonks at Stanford who were themselves the head of Red Cross, the head of the Children's Bureau, the head, and Fernando being a graduate from there in the Heller School of Policy, can appreciate what kind of a live wire environment it was. To top that off, I had the benefit of, as a Southern girl, having escaped to Stanford, and as for my undergraduate and Berkeley, and the free speech movements did not miss my view in that, but also being in Boston, as I was at Brandeis for at least 4 years, witnessing and participating in the civil rights movement, the feminist movement, the anti-Vietnam War movement. It was a very enlightening and encouraging set of ideas that I developed from that, and it set off in the social sciences a lot of radical stuff. And so I attribute much of the work that I have been able to do and contribute to these early ideas. And when I got to UCSF, what a gift. There were women here who were leaders and mentors. I had never had a woman teacher or mentor of any kind. And Greta Stiles, who was dean, Jenny Olison, who was my department chair, who recruited me and was building women's studies and health as a whole field at the time. And Margaret Clark, an anthropologist of incredible note whose work had been on Mexican Americans and health and was devoted to issues of inequality and also to breaking the barriers down. And not to mention that we had the good fortune of Shirley Chater, who was a nurse and was actually in my department, please. When I was department chair, she would call me up and sort of tease me about that. And if only I had known what power I might have had over her as my faculty member, I might have asked for quite a bit more than I knew about. But I learned much more from her, and she accelerated these skids for the passage of the Board of Regents on the Institute. So I'm going now to just acknowledge the three other women who were very significant in the life of the Institute. And Dorothy Rice has already been mentioned. She was our leading star from the National Center for Health Statistics, who came to the School of Nursing and to our department. And then along the way, Maggie Kuhn and Tish Summers. Maggie was the founder of the Grave Panthers, and Tish Summers was the founder of the Older Women's League. They were all co-founding, but they were pushing us and pushing me toward more critical question authority perspectives and question authority in our disciplines. And as many of you know, our Department of Social and Behavioral Sciences, both in women's health, in the sociology of science, science studies, and in the radical micro-sociological perspectives, was a pace setter. I also want to mention the importance of the Institute for Health Policy Studies as a collaborator and a collaborating entity, not the least of whom was Philip Lee, who now has the Institute for Health Policy Studies named after him, who was an enormous coach and mentor and co-conspirator, I think, in the politics that were involved in getting an institute off and running. So I will just say that our work has been inspired by several values. So I'm going to just step back for a minute. You mentioned the Aging Health Policy Center, which Greta Stiles established in 1979. Our research group with Bob Newcomer and Jim Swan and Ted Benjamin and Juanita Wood was in formation, and Charlene Harrington joined us shortly thereafter. In 1980, we were named the National Policy Center on Health, the only one that the administration has ever had. And it was a short-lived enterprise because of interruption of funding from a certain political party that did not think that having public policy information that was aimed at distributional effects was a little bit dangerous. So here we are, the ORU that Wendy has talked about, $325 million, including $40 million of indirect costs for UC. And our group before that had raised nearly $25 million also. And that's not to mention the incredible collaborative research and training grants that we had. So the mission, as Wendy mentioned, is to foster the multidisciplinary collaborative research in health and aging. And I want to just step back and say a word about values. And I attribute this in no small part to the integrity and respect and authenticity of my colleagues and co-investigators and co-principal investigators and principal investigators and co-founders. And those values include very much public interest concerns. And we were and still remain quite unique in the idea of the translational kinds of work that we were doing from the very beginning with testimonies and research reports and congressional, but a commitment and a recognition of the collaborative and through co-authorship and team building. And this meant more of that integrity passed down, a commitment of many to the critical and asking the tough questions. And it was unusual in the academy. In fact, it was discriminatory if you were mainly involved in policy instead of in other kinds of work. And so we pioneered in the types of work that Carol Weiss of Harvard has talked about, the instrumental knowledge and the Enlightenment knowledge development, and the instrumental being the working on the details, the micro and meso, if you will, mid-level and macro-level details of policy and their effects, but also on Enlightenment knowledge. And I'm looking now at Sharon Kaufman, thinking about Enlightenment knowledge, the insights from the development of in-depth understanding of certain issues like death and dying in the hospital, and how a whole paradigm of thinking about that is opened up for change and revision, if not outright attacked. Going along with values, of course, is the social justice element. And from the beginning, we have been concerned about inequality, social inequality, and the extent to which populations, vulnerable populations, are affected. And first it was the attention to these issues, and now we are deeply embedded in work on the focus of these issues. The focus of, not the issues, but on the populations, with understanding of the instrumental and institutional racism and sexism and other forces in our society that are impeding progress in this area. I will say, in terms of training, we must have had hundreds, I know we have had hundreds of fellows, both pre and post-doctoral and international fellows and so forth. These are the disciplines that have flowed through and worked throughout our programs, and it is cutting cross lots between the disciplines where the barriers and the cutting edge can often arise. And we're very fortunate to have had initially, primarily, we had anthropology very strong, sociology strong, public health, social work, political science, and economics just sort of peeped in the door when we managed to get two major grants on state policies in Medicaid and long-term care. And our reviewers said, you must have an economist on this project. And Wendy Max was one of the scholars who came in as a consultant, and then we nabbed her when we could. So many areas of research, and I can't go through all of these. We'll be hearing from different individuals, but aging and disability and long-term care are a key area. Healthy and active aging, and Anita Stewart is here, and we need to give her a shout out for the work that she has done in terms of health outcomes and bringing it to the public community measures. And she was always, she is a giant in outcomes research, and absolutely baseline best. So, Anita, thank you. So we will talk more about these things, but I do want to acknowledge the Disability Statistics Center. We were the first and only National Center on Disability Statistics, and that center was the author of the first recognition of the fact that the young disabled are in almost equal percent to the old disabled, and that was a shocker in the national array with Mitch LaPlante and Stephen Kay. And Charlene Harrington has taken that work with them much further through work on national needs for social supports and independent living, and many of the aspects on personal assistance. The hearing loss, I'm just going to mention, is another kind of collaboration that we have had with Meg Walhagen and with Bill Strawbridge, who are very much involved in hearing loss. And of course, Wendy is always involved in almost every project as our cost of health and of service provision and cost savings. So, all right, I am going. Health of diverse populations is another important area, and we have a national and international effort in this. And this brings me to the cost of smoking, which of course Wendy and the impact that her and Dorothy Rice's and the team's work on smoking has made in terms of the attorneys general of the U.S. and being able to really decide how much of a penalty would be made by the cigarette tobacco industry and so forth. LGBT National Center for Lesbian Health Research, we need to give a shout out to Sue Dibble, who is here. And this is the first, and it probably is the only lesbian health center in the U.S. Sue, thank you for that. And she and her co-founder have a book, Lesbian Health 101, which was a School of Nursing Press edition, and that is out there on the stand. But looking at LGBT issues in health and for women and men as well is a very important part of what we're about. The health economics we'll hear more about, but Wendy and Dorothy get the gold medal for health economics, and I understand today that we now have a group of about 7 economists, and that is quite a team, considering we started out with none and had to sneak one in once we got funding in order to keep it, of course. We had to be forced to drink from the economists. There's, a long time tension between them. And of course, the translational genomics and the wonderful work that is going on there with ethical, legal, and social implications of that. And Barbara Koenig, I don't know if Barbara's here today, but we are very proud to note that we have secured a grant for advising California about what to do with its end-of-life legislation. So we have a plethora of research centers, a plethora of impact on policy. I'm not doing it justice, but just even looking at the cost of home and community-based services and the cost savings therein enabled us to seek and attain funding and support for legislation that would increase resources in that. We've always been consistently aware of the intergenerational linkages and that there is much to be learned, young and old together. And Maggie Kuhn, co-founder of the Great Panthers, and Tish Summers, co-founder of the Older Women's League, and Bob Ball, Commissioner of Social Security, were here as scholars, among others, and enlightened us. So I'm going to close with the Chancellor's priorities and just simply say that the Chancellor's priorities are very much part of what we do and where we are going. And Wendy Max and Pat Fox, who is his work in Alzheimer's disease and the leadership of the Institute in so many forms with Wendy Max has paved the way for the bright future. So the legacy of the translational sciences, which really we started with in terms of applied social policy research and staking a claim for that, and really building the field of aging policy research and big data, the concept of big data. That was ours with the 50-state studies and triangulated methods using qualitative and quantitative and cost and expenditures and services and access kinds of questions. And obviously, the equity and inclusion is now a crucial part of our research agenda and will continue to be so. So I would just close with a concept. There's never been a more important time for our critical edge to continue and to probe deeply. As I heard at a recent gathering, when you see a turtle on top of a post, you know it did not get there by itself. Somehow, we must be asking the critical questions and setting the future forward for the transformations we must make. Thank you so much. What an honor.
One of the saddest days of my academic career was in June 2013 when Pat Fox formally retired from UCSF. He and I had served as co-directors of the Institute for Health and Aging for 14 fun-filled years, and as associate directors for several years before that. He became my close friend, collaborator, commiserator, partner in crime, and we enjoyed our work at the Institute together immensely. Pat holds a PhD in sociology from UCSF and served as a faculty member in the Department of Social and Behavioral Sciences, where he's now Professor Emeritus. He's a fellow of the Gerontological Society of America, and his research focused on the sociology of Alzheimer's disease and health and social utilization, and he conducted extensive work related to health promotion with colleagues at the California Department of Public Health in Sacramento. In addition to his important research, he inspired numerous students, served on many important and some very time-consuming committees, both at the UCSF level and at system-wide in the University of California. He also has a long-standing collaboration with colleagues in China who are interested in long-term care. In honor of Pat's retirement, we have established the Patrick Fox Fund. This fund honors the research, education, and public service work that Pat conducted over his 30-year career at UCSF, first as a student, then as a faculty member. The fund will support student and faculty research-related needs at the Institute for Health and Aging. Whoops, I hit the wrong thing. As well as support students in medical sociology and nursing health policy in the Department of Social and Behavioral Sciences. We particularly welcome students to apply who are conducting aging or women's health research or who come from backgrounds that are underrepresented in graduate student and faculty populations. You'll find more details about the fund on the program, and there's also a link on the invitation if you would like to donate. Please consider contributing to this worthy program. And now I'm delighted to turn the podium over to Pat.
Good afternoon, everyone, and thank you for celebrating the Institute's 30th anniversary with us today. I've been asked to discuss the Institute's longstanding partnership with the California Department of Public Health, or CDPH. Carol's remarks on the establishment and evolution of IHA, from its formative years to its emergence as one of the premier research institutes devoted to health and aging policy, highlights the groundwork and infrastructure created by the leadership, faculty, and staff, which really made possible the emergence of a sustained productive partnership with the CDPH that was to grow and evolve into 27 years of research and public service activities. These activities were closely aligned with the Institute's mission to foster multidisciplinary research, education, and public service in the fields of health and aging. Today, I will discuss the evolution of that relationship, including the accomplishments derived from it, the opportunities that emerged from it, and the challenges that arose in working in and navigating the different organizational cultures of UCSF and the CDPH. Although there were Institute faculty that had previously worked in partnership with the state of California, it wasn't until 1986 that a much more extensive working relationship took hold and grew substantially during the 1990s and 2000s. At its peak, the partnership's projects employed slightly over 1/2 of the Institute's approximately 150 faculty and staff at the time, and accounted for about 1/2 of the Institute's annual extramural funding that at its apex exceeded $23 million per annum. In 1985, the California legislature created the Alzheimer's disease program. Because the CDPH had, at the time, no in-house expertise with Alzheimer's disease, or in working with academic medical centers, which they had to forge relationships with based on the original legislation, they sought the assistance of the Institute. The trust and good working relationships established in this effort formed the foundation of the subsequent rapid expansion of collaborative activities. In the decade of the 1990s, partnerships were also formed in breast and cervical cancer screening with CDPH, as well as cardiovascular disease, diabetes, preventive health care for the aging, chronic disease self-management, and nutrition and physical activity promotion, among others. The decade of the 2000s saw the building of partnerships with other state agencies, as well as the expansion of CDPH efforts in the areas of childhood asthma, refugee health, maternal and child health, obesity prevention, child maltreatment mortality surveillance, and arthritis. We partnered on a variety of initiatives, such as building a statewide Alzheimer's disease scientific proposal peer review system, multiple public health data systems, and we developed a lot of small area geographic information analysis techniques. There were many accomplishments that emerged in this partnership, and I'll just highlight a few to give you an idea of the breadth of our work. The Alzheimer's disease program that I mentioned earlier emerged as a model in the US for multi-site cooperation in clinical data collection surrounding people with Alzheimer's disease and concerning their clinical characteristics and the issues with their care. CDPH funded centers at UCSF, UC Davis, UC Irvine, UCLA, UCSD, Stanford, and USC. And from the outset, all groups recognized the value of collaboration and pooling common data, with the Institute fulfilling the role of the data coordinating center. Now, this effort, which began in 1986, developed one of the largest data sets in the world on people with Alzheimer's disease at a time when large-scale research efforts into the disease were in their infancy. This type of collaborative spirit and effort was long sought by the National Institute on Aging for the Alzheimer's Disease Center network that was emerging at about the same time. But it was not a goal that was achieved at the federal level until 1999. Another important collaboration arose in 1992 when the CDPH received funds from the Centers for Disease Control and Prevention, or the CDC, to establish a breast and cervical cancer screening program for and underinsured women in the state. The CDC funds were sufficient to screen approximately 30,000 women per year, which was far below what was needed given the number of women in California who required improved access to such screening services. Now, this effort was dramatically expanded when the California legislature created the Breast Cancer Early Detection Program 3 years later. There was enormous pressure from the legislature and advocates at the time to get the program up and running as soon as possible, as it was a high-profile effort riding the tide of national and state interest in women's health issues. The result was a combined federal and state breast and cervical cancer screening effort that today serves over 200,000 women annually. The CDPH called on the Institute to develop and implement a system to fulfill data quality indicator and core program performance indicator reporting requirements, as well as to evaluate the efficacy of the program. Among other things, the data were used by the CDPH and the CDC to ensure that women were provided appropriate services in a timely manner. The Institute established and refined this system for over 20 years, and in 2012 it was incorporated into the California Department of Health Care Services, which is the agency responsible for the Medi-Cal program. Similarly, for over 20 years, the state's diabetes control program was led by Institute faculty and staff who examined the social determinants of health to change the conversation about the prevention of type 2 diabetes among California's most vulnerable populations. They also developed innovative approaches such as the use of community health workers in vulnerable communities, emphasized tobacco cessation programs targeting people with type 2 diabetes. They developed an online learning community with the Diabetes Information Resource Center, as well as spearheaded Diabetes Prevention and Management Initiative for Medi-Cal beneficiaries as part of California's 2007 healthcare reform efforts. We also collaborated with the CDPH in establishing a data system for the Preventive Healthcare for the Aging Program, or PHCA. PHCA provided public health nursing, health promotion services to approximately 22,000 older adults per year throughout California, and the data system was used to track the health status of seniors, progress in meeting program goals targeting prevalent chronic diseases in specific communities, as well as evaluating program outcomes. Beginning in 2000, Institute staff worked with the California Office of Traffic Safety and the California Department of Transportation to secure funding for public health efforts aimed at developing the concept of livable and walkable communities to enhance closer integration of traffic planning with community efforts to promote physical activity. This was one of the initial efforts to partner across agencies and state government concerned what had historically been rather disparate responsibilities. That is, public health on the one hand, and the development and maintenance of the state's roads and highways on the other. Now, in addition to these and other accomplishments, the partnership also resulted in synergistic opportunities to integrate with other Institute faculty who had been working for years in research on aging, health and long-term care, as well as health economics. One of the earliest examples of this was a seminal study on the cost of caring for people living with Alzheimer's disease, funded by the National Institute on Aging. Faculty in the Institute's Dorothy Rice Center for Health Economics collaborated with the CDPH-funded UC Davis Alzheimer's Diagnostic and Treatment Center to examine the formal and informal costs of caring for people living with Alzheimer's disease in both community resident and institutional settings. It was the first such study done which examined the value of informal care provided by caregivers whose family members had been institutionalized because of Alzheimer's disease. Arguably, the high point of the synergy was the Institute being competitively awarded the Medicare Alzheimer's Disease Demonstration and Evaluation Project from the United States Healthcare Financing Administration, HCFA, or HCFA as it was called. It's now known as the Centers for Medicare and Medicaid Services. The Alzheimer's Disease Program partnership that had been established in California was an important activity to establish our Alzheimer's credentials. But what was even more important was the work senior Institute faculty had previously done on the HCFA Social Health Maintenance Organization Demonstration Project Evaluation. Bob and Charlene were, of course, the principals in that study. And this previous work, I cannot emphasize how important it was because it significantly helped establish the legitimacy of the Institute in conducting large-scale health policy research projects. The Alzheimer's demonstration was very complex, with sites in 8 states involving over 8,000 Medicare beneficiaries and their caregivers. Another example was the work Institute staff were doing in medicine and public health that provided the groundwork for a 3-year project in collaboration with community health clinics throughout California to reduce health disparities among school-aged children with asthma. The project produced major improvements in asthma-related care processes and clinical outcomes. Over time, children had fewer acute and emergency department visits and hospitalizations, fewer frequent daytime and nighttime symptoms, and fewer missed school days. In these and other opportunities, it was never clear a priori whether such synergies would arise from research or public service projects, which was somewhat ironic given that in a place like UCSF, research projects were always the first to be emphasized as most desirable. While the relationship was long and productive, there were pitfalls that emerged during the course of the CDPH collaboration. Many of these centered around differences in organizational culture. The culture at UCSF, and especially the Institute, was generally one of openness to new ideas, few, if any, constraints placed upon the expression of ideas and the investigation of topics, and while there was an organizational hierarchy, it was not as rigid as can be found in other types of institutions. In working with the CDPH, while there is openness to new ideas, their expression is much more constrained by the political implications for the administration in power. The net result is that ideas may not come to full fruition, largely because there are always political ramifications to be weighed. The process of governing is sensitive to the implications of different public health policy approaches. This is largely because of the effect that such approaches may have on constituent groups and partners involved in or affected by such initiatives. And there is always an assessment of the cost to state government of a new idea or approach. An example from the cardiovascular disease program illustrates the political considerations of information. We had conducted an analysis of cardiovascular mortality rates in California cities and had produced a report on the topic that was to be released as a CDPH report. Before release, the report had to be reviewed by CDPH upper management and then by the governor's office. This process took about 6 months, and most of the changes were relatively minor, largely amounting to using different layouts and fonts, but a substantive recommendation was omitted from the final report. Now, it is well known that there is a very close relationship between socioeconomic status and health, such that populations at the lower end of the socioeconomic scale tend to have poorer health and earlier mortality than populations at the higher end. This trend was evident in our analysis of cardiovascular disease mortality, with cities composed of larger numbers of low-income residents showing higher rates of mortality than cities composed of relatively higher income residents. The recommendation that was omitted from the final report was one suggesting that the state should promote economic development in poorer communities with the goal of reducing regional economic disparities, and from this, health and mortality disparities. Needless to say, this was the first and only scientific report that we attempted to release under the auspices of the CDPH. Now, there may be some of my colleagues that will find this next observation difficult to believe, but nevertheless, it is true. The administrative structure of UCSF was much more efficient and streamlined compared to that of the state. This was probably most clearly evident in the relative ease with which we at UCSF could hire new staff and procure needed services to get the necessary work done in a timely manner. The state civil service system is rather cumbersome, and procuring goods and services within the state system can present significant challenges. Part of the former is due to the fear of adverse publicity concerning the, quote, unbridled growth of government, unquote, that both Republican and Democratic administrations desired to avoid. Part of the procurement difficulties were due to a series of press revelations concerning large state projects that resulted in systems that either did not work as promised, had significant cost overruns, or had not been competitively bid. The clearest example I remember was the DMV procurement of a new computerized data system that was costly and never really actually worked as hoped. But there were also pitfalls that affected both UCSF and CDPH equally, and they largely had to do with the multi-year failures of the legislature and governors to pass a state budget. These conflicts were routine, and it seemed that hardly a year existed where a budget was passed on time. The result was a staff morale roller coaster that had to be managed by keeping everyone in the loop on how we were dealing with the budget uncertainties. As I noted earlier, one of the central reasons the Institute's relationship with the CDPH was so durable was the high level of trust that had developed over time. For years, most of the work we initiated began way before a final contract or grant agreement was fully executed. This was primarily because the programs had to be implemented and funds spent within fiscal years. And there were very rarely mechanisms to roll over funds from fiscal year to fiscal year. If you didn't get started, you would lose large sums of money appropriated for one important public health issue or another, funds which could rarely, if ever, be recovered. And this was of special concern because it was generally the case that the funds California received from sources such as the CDC for public health initiatives were generally not at all proportionate to the size and population of the state. With the advent of the Great Recession, economic and political pressures increased as both institutions tried to adapt to shrinking resources, albeit with the same scope of responsibilities. UCSF and system-wide UC policies, as well as CDPH and Department of General Services policies, changed substantially, effectively limiting such historical practices and eroding the culture of trust and the we can get it done attitude that had existed for over 2 decades. Now, it's ironic, I think, that we humans sometimes have trouble recognizing when we have it good, and it is usually only after time has passed and our situation changes that we realize in retrospect just how good we had it. This is the way I think of the work with my UCSF and CDPH colleagues. During our lives together, I encountered some of the most dedicated, compassionate, and wise people who worked tirelessly to address a host of the most compelling health issues that California faced and continues to face. This dedication to working to improve the health of individuals and communities and to examining some of the most compelling health issues of our time continues within the Institute, as you will hear from our next group of presenters. I feel most fortunate to have had the privilege of participating in these efforts and to having had the opportunity to work in the Institute with CDPH and on this great campus. Thank you.
So now you have a bit of a sense of sort of, I hate to say the past, but how we got to where we are today. The next part of our program will focus on the ongoing research, the current research of our faculty. So our first speaker to talk about ongoing work is Dr. Marcia Mickey. Marcia holds a PhD in anthropology from the University of North Carolina, Chapel Hill, and joined our faculty in 2014. She completed a postdoctoral fellowship at the Center for Integration of Research on Genetics and Ethics at Stanford, supported by a Career Development Award from the NIH National Human Genome Research Institute, NHGRI. That rolls off my tongue now. I'm getting good, huh? She has conducted qualitative research on families of children with genetic disorders, on the understanding and self-perceptions of genetic research participants, and on individual and community religious identities. Her current research, supported by NHGRI, examines the social and ethical issues in the translation of non-invasive prenatal genetic testing. She joins a growing and active group of researchers at IHA and UCSF who are conducting research on bioethics and translational genomics. We gave Marcia a tall order today, asking her not only to talk about some of her own work, but also the work of the larger group that's really one of our most vibrant groups at present. So Marcia, look forward to hearing from you.
When we think about the life course and bioethics, really there are bioethical concerns at every possible stage, from before we think about life even beginning, preconception issues, all the way to after we think of life ending, so end-of-life care and dealing with post-mortem issues. And we have many projects that are associated with various issues related to this. So we have a lot of great projects going on here at IHA that deal with with lots of these areas, from the beginning to the end, so to speak. And I'm going to talk about a few of those. But since I'm sort of bridging past and present in my place on the program, I'm just going to take a moment to talk about the important position that and role that UCSF plays in bioethics as a field. Bioethics is actually a very young field. Academically speaking. And one of the founders of the field was Al Johnson, who many of you may remember was here for many years at UCSF. Al was here from 1972 to 1987, and 1972 is a very important year in bioethics. That is the year that the atrocities related to the syphilis study at Tuskegee were revealed. And 2 years later, the National Research Act was passed, which created not only many of the regulations about human subjects research that we have today, but also a bioethics commission. Dr. Johnson was on that commission. He was one of the co-authors of the Belmont Report, which could be thought of as really the foundational document of the field of bioethics. He was also a huge figure in clinical ethics. While he was here at UCSF, he co-wrote this textbook, which is now in its 8th edition, very, very widely used, pioneered the 4-box method for clinical ethics consultation. And he then went up to the University of Washington, headed up their bioethics program for a long time, and he's now back down in the Bay Area. He's actually at CPMC consulting on bioethics there, and they've produced a really just lovely YouTube video about him. If you're at all interested in seeing it, they did a terrific job, and I enjoyed watching that. The next major figure in bioethics here at UCSF was Bernie Lowe, and Bernie Lowe came here under Al Johnson and then took over bioethics, the medical ethics program in the School of Medicine after Dr. Johnson left. And Bernie Lowe's really a very well-known international figure in bioethics. He created, for instance, this is one of the many things he's worked on, but this is a textbook that's frequently used for research ethics classes, responsible conduct of research classes. We use it here. And he left UCSF, or sort of left UCSF, to become the head of the Greenwall Foundation, which is the private foundation that funds a great deal of the bioethics research that happens in this country. He actually does still maintain, though, his faculty position here at UCSF, so we haven't completely lost him. Maybe one of these days he'll come back to us full time. In 2011, Barbara Koenig came to UCSF. Barbara is also an internationally known figure in bioethics. She's a fellow of the Hastings Center. She's done tons of research on not only clinical ethical issues, but more recently what we call ELSI issues, ethical, legal, and social issues, particularly in genomics. And she's a big figure in that area, which is huge and still growing. She did a lot of work on race. She did a lot of work in the early HIV and AIDS epidemic, and her work has been really influential on me, as I'm also a medical anthropologist like Barbara. And one of the first things she did when she came to UCSF, to IHA, was to secure funding from NIH and NHGRI to start a Center for Bioethics and Translational Genomics, a center of excellence called CT2G. and that I'm a collaborator in that center, and that's one of the things that really encouraged me and inspired me to come here. But I don't want you to think that Barbara's a newbie like me, because she's not. She actually has a great history here at UCSF, and that's her in the middle, if you don't recognize her. Back in the 80s, Barbara came here, she's trained as a nurse, and she came here and was a staff nurse in pediatrics in 1975. She then began the medical anthropology program that is a joint program that still exists between UCSF and Berkeley. She finished her PhD in 1988, and before that, she had worked for Al Johnson in the Department of Medical Ethics, or the Program of Medical Ethics, and then afterwards, she became a faculty member for 5 years. She only left to become the first full-time director of the Stanford Center for Biomedical Ethics. So then again, I benefited from the seeds Barbara planted because I was there much later. And then she went to the Mayo Clinic and headed up their biomedical ethics program. So we're so lucky to have her back again. And so in addition to CT2G, which Barbara founded, we're also doing a lot of other things to create infrastructure for ethics here at UCSF. Out of IHA, Barbara received funding from the Chancellor's Office to create an infrastructure for bioethics here at UCSF that allowed us to hire a program manager and to take on some other initiatives. And she's also one of 4 PIs in the UC North Bioethics Collaboratory, which is a collaboration between the 4 northern UC campuses, so Berkeley, UCSF, Santa Cruz, and Davis. And we're doing some really remarkable work there. We just got started, and I'm so excited about the work that's happening there. And I told Barbara before she left, I said, I'm going to talk about how IHA is now the epicenter of bioethics at UCSF. And she says, that's not really how I think about it. I really think about it more as an incubator. And I just love that idea of IHA as a bioethics incubator. It's a place where ideas can be nurtured and collaborations can be formed, and we can birth projects that really benefit all of us in California and around the world. So I'm just going to talk about a few of those very, very quickly. I don't have a lot of time, but I have 4 projects picked out that I just want to highlight what kind of bioethics work is going on here at UCSF and particularly at IHA. And I'm going to start with my own work, not so much because it's mine, but because if we're going by the life course, I'm at the very beginning. So my current work is about prenatal testing, and particularly about new technologies for using cell-free DNA to elicit information about a fetus during pregnancy without any kind of invasive procedure. So using just a blood draw, we can now find out all kinds of very interesting information based on the cell-free DNA that circulates in all of our bloodstream, and that in pregnant women is partially from the fetus, or more accurately, from the placenta. Of course, as with any kind of prenatal testing, there are always ethical concerns. Particularly with this technology, there are a lot of concerns about the commercial interests that have developed these tests and continue to aggressively market them. So that's a concern that we're watching very closely. So related to that, we worry a little bit about the fact that there is not always clinical validation for new applications of this technology. It began as a test simply for trisomy 21 or Down syndrome, and now there is it's progressed to look for literally hundreds of different conditions in the fetal genome, and we don't have published clinical validation for all of that, so it's not always clear how clinically useful and valid it is. We do need a provider education. This is such a new technology. It only came into the clinic in 2011, and particularly for non-specialists, this is a very small part of what they do, and it's very difficult for them to keep up with fast-moving and extremely technical information, so frequently they get their information from marketing reps. Along with that, because of the ease of the test and the lack of some provider education that's standardized, we do worry about the erosion of informed consent for pregnant women, and informed decision-making is always a difficult and delicate process for prenatal testing. One of the reasons for that is because pregnancy in this country is increasingly becoming medicalized. Even though the vast majority of pregnancies proceed perfectly normally, they're a normal part of our life course, they are increasingly surveilled by the medical professionals, and we're a little bit concerned about the ways that even minor genetic conditions can be seen as something that must be monitored. Of course, we're worried about a potential rise in terminations that may result from some of these conditions, which may be very, very mild phenotypically, but when you discover that there's a genetic change in your fetus, suddenly there's a lot of fear associated with that. And finally, of course, we worry about issues of healthcare cost and differential access and health disparities. So my particular project is a great example of a case of translational bioethics. So we have technology that's currently still being developed in the laboratory. It's also in the clinic. Many of the applications of it are sort of betwixt and between. The blurring of a once bright line between research and clinical care is happening here. And so you may ask who the stakeholders are. Certainly we know that patients and providers are, but there are many, many others. I've been more recently working with a lot of advocates for people with disabilities. I've been talking to folks who are reproductive advocates, people who have religious concerns about the technology and so forth. So there's lots of stakeholders involved here, including lab directors who are now receiving licenses for this technology and developing them in their own labs. What can we learn from this? Well, I hope that we can learn not just about this particular technology, but about ethics and social issues in all kinds of translational genomics, and make recommendations about how to move ethics upstream and how we can integrate ethics more effectively into the translational pathway for genomics. So just to mention, I'm doing this work under a grant from NHGRI, as Wendy mentioned. I'm the PI of that grant, and here at IHA I have a wonderful research assistant, Roberta Ryan, and I'm so happy to have her. And then I have lots of collaborators all across the country, and in fact also in Canada. We've developed a research consortium, and if you're interested, you can learn more at prenatalinformation.org. So I'm going to move just a tiny bit up the life course, not too far though. I'm going to talk a little bit about newborn screening, and particularly about newborn sequencing, which is, a new place in which genomics is being integrated into healthcare and even public health. You may know that every state has its own newborn screening program in which blood spot is taken from a heel prick on babies when they're brand new, and lots of wonderful public health outcomes for that. Also, lots of research being done with those blood spots. It's a tremendous resource, especially here in California. We have a huge resource of newborn blood spots. But of course, there are ethical concerns, as there always are. One is when we think about integrating genetics, particularly into this, we worry about interpretation and curation of the data. What results are valid? What results are clinically relevant? And how are we going to interpret those for patients? Informed consent is not normally received for newborn screening because it is a public health initiative, but we do have a new federal law that says that if you want to use the blood spots that are left over from newborn screening for research, which almost every state does, you need to get informed consent, and implementing that is going to be a huge challenge. We certainly have concerns about the return of results and how to counsel parents about those. Particularly because genomics has family cascade effects. You may find something out from screening a newborn about many, many members of your family. And this could have effects on life and disability insurance. You may know that we do have a genetic non-discrimination act, which is a great thing, but it only deals with employment and health insurance, not with life or disability insurance. So if you have a pre-existing condition in your medical record, it could affect your ability to get those kinds of insurance. And of course, genetic determinism is always a question. When you deal with genetics, people think of genetics as a blueprint that's unchangeable. And so when we think about perhaps the determinism that may accompany a genetic diagnosis, you wonder if children may have a right not to know some of these things about themselves. So the project that we're doing here is another great example of translational ethics. This is very new technology that we're thinking about integrating into not only clinical care, but public health. What is possible with newborn sequencing? How is it different from the metabolic screening that we now do? And how does it alter the current screening? Is it going to replace it? Is it going to enhance it? These are still open questions. And of course, we're dealing with a lot of questions about ethical and public health challenges related to this technology. So we do have more than one project actually going on about this. This particular project is a U19 grant, which is a very, very large grant with 3 arms. It has a research arm, a clinical arm, and an ELSI arm, ethical, legal, and social implications, in other words, bioethics. And Barbara is the PI of our U19 grant at NIH. There are 4 of them across the country, and they are teaming up on a lot of their findings. At IHA, she collaborates with Dr. Julie Harris-Way and with Flavia Chen, their program manager, and all three of them are today at the Hastings Center in a meeting about this project, so they couldn't be here today. And we have lots of collaborators here at UCSF and elsewhere. Moving a little far up the life course, we can talk a little bit about breast cancer screening, and I'm so glad that Pat Fox brought up breast cancer screening. California was, of course, a pioneer in this public health initiative, but today breast cancer screening can mean more than just mammograms and manual exams. We also know about several genes, the BRCA1 and 2 genes particularly, that affect your propensity to have breast cancer, and the question of how to integrate those kinds of things into your screening program is a big one right now. There are ethical concerns, of course, about that. We worry about maximizing the beneficence from screening programs, which we know exists, and yet worried a little bit about overscreening, which can lead to unnecessary treatments. And right now, we know that the national recommendations about breast cancer screening are in flux because there is some question about whether we're overscreening some women. Overscreening can also lead to psychological harms from false positives, and we do need a strong evidence base for public health screening, which we have been working on for many, many years to make sure that we're doing the right thing. Informed decision-making is, of course, always a big concern for bioethics, and we do worry about systemic healthcare costs. That is an ethical issue in its own way. So the project that's going on right now is looking at the barriers to translating this new form of risk-based cancer screening into clinical practice and public health. And what we're doing is collaborating with the Athena Breast Health Network. They have a study going on right now called the Wisdom Study, and they're looking at integrating genetic findings, family history, mammography history, and so forth into creating a personalized risk-based screening program for women so that some women who are going to be at very, very low risk may not need to be screened quite as often, and other women who do need more frequent screening will get what they need. In that context, we have to think about, of course, how to manage genomic uncertainty and the return of results. And think about how families are affected, because of course, as I mentioned, when you have genetics involved, whole families are now the object of your attention. So will this precision screening increase health disparities? This is another open question and one that we're also looking at. Right now, we have a RAP grant seed funding to start this work. We also have written it into the renewal for our Center of Excellence, our CT2G Center, so hopefully we'll receive even more funding because that's going to be our central project when we get our renewal. Barbara is the PI of the RAP grant, and she's working at IHA with some great staff members, Janica and Lindsay, and then we have several collaborators across the UC system. So, we had a mention earlier about physician aid in dying, and you may know that there is a new law in California modeled on the one in Oregon and some other states that has now legalized physician aid in dying, and that's on its way to coming into effect. This is an issue that, of course, is very controversial, has lots of ethical implications, and as soon as the law was passed, which was kind of a big surprise to a lot of people, there wasn't a lot of publicity about it ahead of time, we sort of jumped on that here at IHA and wanted to address it. I don't even have to tell you what all the ethical concerns are probably with physician aid in dying. There's a lot of concern about respecting patients' autonomy, and yet many people have concerns about the sanctity of life. The compassion for suffering for people who have terminal illness is a big part of the physician aid in dying movement, and yet we do worry about the potential for abuse. Medical professionals here at UCSF and elsewhere are also dealing with value conflicts when it comes to this new law. It's a big role reversal for them to take on this role of helping people end their lives. And we, of course, worry about vulnerable populations and exacerbating health disparities. What's happening here, the project that we have is dealing with questions like how can patient autonomy be balanced with these ethical safeguards? Which vulnerable populations are we really talking about? And who should we be considering in this? And what challenges does this new law pose for healthcare institutions, including UCSF? And to that end, Barbara has secured a short-term California Healthcare Foundation grant. We're going to convene a one-day meeting in December that will bring together ethicists and medical professionals and policymakers and so forth to talk about these issues and figure out how to implement this new law. She's aided at IHA by our esteemed program manager, Lindsay Forbes, who is always making things better here for us in bioethics. And we have a lot of collaborators here at UCSF that are helping make this happen. So in conclusion, when we think about the life course and bioethics being integrated at every stage of the life course, we really have a tall order here, and we're so lucky to have an institute that supports that mission and is really facilitating bringing together bioethics across the 4 professional schools here at UCSF and making us continue to be a leader in bioethics in the nation. So thank you very much for listening, and I look forward to hearing the rest of the presentations.
My good friend and colleague Sharon Kaufman has been part of IHA for 30 years, conducting seminal research on aging and health and mentoring and teaching nursing students as well as others on campus and beyond. She now serves as chair of the Department of Anthropology, History, and Social Medicine at UCSF. Her work explores topics at the intersection of medical knowledge and society's expectations for health. Her research has examined, among other things, the changing culture and structure of U.S. medicine, healthcare delivery at the end of life, the relationship of biotechnology to ethics, governance and medical practice, the shifting terrain of evidence in clinical science, and much more. She's authored many manuscripts and 4 books. One of her books was translated into Japanese, another has been translated into Chinese, just to show the international reach of her work. Her work has been funded by the National Institute on Aging and the National Institute of Nursing Research for 30 years. She's also core faculty in the joint UCSF-UC Berkeley program in medical anthropology, where she's taught for 25 years. She lectures frequently at UCSF and UC Berkeley and mentors students from many departments and postdoctoral fellows and junior faculty from a variety of disciplines. I'm delighted to introduce Sharon to tell you about some of her most recent work. Sharon.
Hello, everybody. It is a pleasure and an honor to be here. And has it really been 30 years, you know? So I want to thank Carol Estes for her vision, and it was an incredible vision to start the organized research unit, well, first the Center for Aging Health Policy, and then the ORU, and her administrative work through the Byzantine networks of the UC Office of the President, et cetera, to get that going. And to everyone who was aboard in the early years, I want to thank Pat and Wendy for their leadership up to the present, and to thank them for being extraordinary colleagues, giving me much support along the way. As a grant-funded faculty member and researcher, everybody here knows that it's a hard road, and you need a lot of moral and therapeutic support, as well as the financial support from foundations and federal agencies. I want to give a shout out to Regina Gudalunas and the staff at IHA, because frankly, I would not have been able to do any of my work, and nor would anybody else here, without the extraordinary, and I mean really extraordinary, dedication and attention to detail that the federal grants, the California contracts, and the private foundation grants require, all of which, of course, as everybody here knows, is a moving target, and their information and directives to those of us who are filling out their forms is changing constantly. So I really give my thanks over a long period of time to all of the staff people who have helped all of us. So I just want to talk about one project, my current project, which of course builds on a lifetime of research looking at issues of medicine, geriatrics, the delivery of clinical care, the issues that physicians, families, and patients face as they grow older. Medicine's ability to prolong wanted life is a positive development. Yet the ability and desire to employ life-extending treatments now exists in an ever-aging society in which many older persons, their families, and their health providers face the quandary of whether those treatments bring with them too much pain and suffering. Where is the line between enough and too much treatment? As a medical anthropologist, I've spent more than 20 years watching this quandary play out in hospitals, clinics, bedsides, and kitchen tables, and asking why it cuts such a wide swath through the public conversation about control over the time for dying. In 2002, I began to observe older patients in specialty clinics, mostly in California, but also around the country, where they were often offered life-prolonging therapies. I listened to hundreds of patients, physicians, and family members deliberate about what to do. I heard them express their hopes, fears, and reasoning. I've had a ringside seat on the evolution of their dilemmas about crossing the line of too much, and at the same time, their desire to do everything possible to prolong life. I started tracing the themes that emerged in clinic conversations about evidence and expectations, norms and standards, risks, hope, and ambivalence, the urge to try everything, and the demand to stop. And believe me, patients and families are often saying all of that at once. The talk mostly settled on scientific evidence, standards of care, risk reduction, and necessary treatments, which led me to investigate how and why these phenomena have come to organize our more is always better approach to medicine. That quest, in turn, led me to think about the larger engines of the biomedical economy, the research and insurance industries, and their impact on what we do when life is at stake. What emerged was my realization that there are unseen, determining forces, a chain of healthcare drivers, behind the dilemmas 21st century medicine poses. I coined the phrase ordinary medicine to reflect the hidden chain of connections among science, politics, industry, and insurance that drives the U.S. healthcare system. Hidden as well is the ethos that supports those connections and impacts self-governance. The multi-billion-dollar biomedical research engine, and I want to emphasize the fact that it's a multi-billion-dollar engine, with its emphasis on the clinical trials enterprise, is where evidence-making begins. The infrastructure and value of evidence-based medicine and the clinical trials enterprise prioritize thinking about what constitutes responsible healthcare. These are the dominant apparatuses of truth-making in medicine. How does this work? Trial findings are converted into best evidence for treatment, and then that evidence generates standards of care. This is how scientific innovation organizes physicians' work, healthcare finance, and patients' and families' expectations about what is normal, needed, and ethically necessary. Evidence-based medicine is itself complicated by three interrelated developments that permeate American life and that control the quandary of where to draw the line. These are, first, the increased role and influence of private industry. Let me give you a shocking example. In 1980, 32% of clinical research in the United States was funded by private pharma, device, and biotech companies. Today, 65% of biomedical research is funded by private industry, whose goal is always to increase market share. Their goal is to look for markets, and of course, the elderly are a growing market. Second, all those clinical trials have generated more evidence of therapeutic value and an ever-increasing number of standard, that is, difficult to refuse, treatment options. Third, our national priority on new technologies has influenced our collective perspective on the timing of death. Today, in the United States, most deaths, regardless of a person's age, have come to be considered premature. So how does evidence-based medicine play out in the clinic and in real lives? I draw from the example of the implantable cardiac defibrillator, the ICD, that little tool, this big, like a pacemaker, implanted under the skin, easy to do, designed to correct a potentially fatal heart rhythm. You know, the ICD is the small computerized version under the skin that replaces the big paddles that are used in the hospital that you see on the opening episode of ER on TV. This is a therapy that has shifted from unthinkable a little over a decade ago to routine and standard for older persons in the United States today. It became thinkable and doable when evidence from clinical trials showed good survival rates and when Medicare began to reimburse for its use. The ICD was used sparingly until 2002 for those who already had survived a potentially lethal heart attack but were at high risk for another one. Then its use began to rise substantially. Why? 9 clinical trials of ICD use were conducted between 2002 and 2005, each one showing varying degrees of benefit among patient populations that had not experienced a potentially life-threatening heart attack. Taken together, the findings from those 9 trials provided increasing evidence of benefit of the ICD for survival, and that evidence led Medicare in 2005 to expand the eligibility criteria for reimbursement to include primary prevention for those who'd never suffered a potentially fatal cardiac rhythm. The floodgates opened, as you would expect. Now, these devices have become the standard of care for patients with moderate to severe heart disease. The important thing about the ICD is that in treating a potentially lethal arrhythmia, it prevents sudden death. That is, the silent heart attack in the night, the kind of death everyone says they actually want in late life. Yet the device is difficult to refuse, even in very late life. Why? Because evidence organizes its expanded use, and because it seems to go against medical progress and common sense to say no to it. It has become an ordinary part of the medico-ethical landscape. The effects of this logic most affect the oldest patients. There's no question of the unequivocal good of this device for preventing young people from dying. Yet today, more than 110,000 patients in the US receive ICDs each year. Most persons with ICDs are older and sicker with underlying cardiac disease, and the electrical shocks from the ICDs do not necessarily extend an older person's life or improve its quality. Indeed, the ICD transforms the immediate risk of death into the near certainty of progressive heart failure. The hope of this life-extending treatment comes up against a prolonged, unwanted kind of late-life living and dying. An 86-year-old man I interviewed succinctly summarized the dilemma for me at one clinic I visited. 2 years earlier, following a third heart attack, he had received an automatic implantable defibrillator. He said to me, "After I passed out and was taken to the hospital, the cardiologist said I should get an ICD. He said he wouldn't be doing his job right if he didn't say that I needed an ICD. So I agreed, and he put it in. Now, it seems the ICD has prolonged my life a little bit, but the longer it prolongs my life, the more other things are happening to me that it can't correct. And you know, all the medicines, all the treatments have side effects, and some of them are pretty bad. So which do you want? The question is, do you want to have the other things that are going wrong and the side effects, or do you want to end it all, and when?" Physicians have conflicting views about the use of this device as well. One physician, similar to many others we interviewed, reflected, "It becomes very controversial sometimes, and maybe that's one of the sources of my personal unrest. Sometimes I disagree, but it's very tricky to sit down with an 88-year-old patient or their loving family, and by now they've heard about this technology, and to say, you know, he does meet the clinical criteria, but really, at his age, it may not be the right thing. If he were to have a dangerous arrhythmia, That's the way people pass quietly in their sleep. So it may not be something that we want to jar your loved one awake with. That's a very hard discussion to have. Okay. Since 20% of those on the receiving end for the ICD are now over 80, and the proportion over age 90 is growing, and in some places it's greater than 10%, the device is reshaping the aging experience and the dying transition for significant numbers of people. It staves off death but does not improve health. It turns life-threatening disease into a chronic condition, enabling people to grow older in need of more intervention, more risk awareness, and more prevention, all at the same time. This is where evidence has come to rest in the case of the ICD, in a new, uncomfortable engagement with one's own role, and let me say also with the family's role, in the timing of death. Older patients and their families must ponder an individual ethic of life extension. For patients, it often goes like this. Given my current age, that is, how long I have already lived, how much longer do I want to try to live, given what the clinic offers? For the family, it goes something like this. What kind of a son, daughter, spouse am I if I don't support the use of this technology? This technology, as so many others, extends wanted life for many people, and that is, of course, the bottom line. That's why discussions about the goals of medicine in an aging society are fraught with controversy. It's why conversations about control over the end of life are so emotional, difficult, and often full of conflict. The issue on the table for all of us is how life-extending therapies in an aging society have been caught up in the perfect storm of what has become standard and ordinary. How and why they bring increasing numbers of patients and families, indeed our entire society, to face the quandary of the line. To conclude with good news, despite the increased influence of the drug and device companies, and let me say, as I think everybody here knows already, their influence is getting stronger and more aggressive all the time. And even though the technological imperative in medicine remains a powerful driver, the medical scene continues to change for the better in many ways. Palliative care is taught in medical schools and practiced widely. Solutions to overtreatment and patient suffering have been implemented in many places. Hospitals, patient advocacy groups, and healthcare systems are working to change the default away from more intervention so that age, comfort, meaning, and mortality are acknowledged. Yet there is still a way to go because of the contradictory fact that we desire new, even experimental medical therapies without limit at the same time that we deplore the overuse of those tools and the suffering they sometimes cause. In that way, the quandary of the line continues to have profound effects. Thank you.
Thank you. So before we go to break, I just want to introduce the Dean of the School of Nursing, Dr. David Vlahoff, to say just a few words. So, David?
Wendy, thank you so much. This is really such a wonderful celebration, being able to sort of review what's happened with the Institute of Health and Aging over the past 30 years, but also to look at the current research that is going on right now. So vital, so vibrant, so timely for the issues that are out there today. As I'm listening to some of the work that was done 10 years, 20 years ago, those are still so very much alive for us today. This was really pathfinders to have path breaking for so many of the issues that are out there for us. I look around the audience today and I see really the pioneers of so many areas of health and aging, and so many more of the topics that go beyond what we think of when we hear the terms health and aging. Carol Estes, I really want to recognize you and what you started here and all the support that you've had from all of the people that have been here in the Institute from the beginning, some throughout the life of the Institute. And also, what a addition this has been for the School of Nursing. When I was starting out looking at the role of dean as I was being considered, I looked through all of the CVs of the faculty that were here, and I thought, you know what, this is a place I have to come to. And a lot of that was from all of the powerful research that was coming out of the Institute of Health and Aging. That's not to minimize anything in the rest of the school, but to say something so special here, not just in the research topics, not solely because of the results, not related completely to the impact which has been used, but also the culture that was established within the Institute to create an environment where you push aside all of the barriers that one might have in terms of disciplinary structures. I think just bringing people together, creating an administration that puts our focus on the work as opposed to, thinking about all sorts of details. So the staff that supported the researchers has just been terrific. And so for me, this is just a wonderful day to be able to be in the audience and learn more from an overview of what people are presenting and to see so many smiling faces as we all celebrate this anniversary. So congratulations to you all, and I'm very proud of you. Thank you.
Now it is my pleasure to introduce Dr. Julian Johnson, who's been at UCSF for 15 years and at IHA since 2009. It's our game. And she's now the Associate Director of the Institute, and just a pleasure to have as a colleague and as a friend. Dr. Johnson is a cognitive neuroscientist who completed her PhD at the University of Texas at Dallas. Her research focuses on cognitive aging and developing innovative ways to improve health and well-being in the community using creative arts. In 2010, she was selected as a Fulbright Scholar and traveled to Finland for the year to study how community choirs promote quality of life in older adults. She built on this experience and obtained funding from the National Institute on Aging to complete a cluster randomized clinical trial of a community choir program to promote health and well-being in culturally diverse older adults in San Francisco. And her study has gotten wonderful publicity. You'll learn more about that in just a moment. Julene also mentors junior faculty, chairs the University of California Humanities Research Institute Advisory Committee, and is part of a UC-wide music research network that received funding from the UC Office of the President last year. So Julene is going to tell us about her inspiring research now. Julene?
Thank you, Wendy, so much, and thank you, Pat and Carol, and everybody else that has been wonderful colleagues and friends at the Institute for Health and Aging. I can't imagine a better place to do my academic work, and I'm really honored. And as you can see from this unusual topic in a health sciences university such as UCSF, that I'm focusing more recently on arts and aging research. And you might ask why, because this is not your typical topic that you would see. And I love this quote by Rhodessa Jones, who's here in the local Bay Area. "Art for art's sake is fine. I don't have the time for it. I think art should save lives on some level. It's about moving us all forward." And she has this fabulous program over in a Theater for Incarcerated Women program, rather. It's called the Medea Project, and it's in this Bay Area. So if you want to check it out, I highly recommend. So today I'm going to talk very quickly about why now, why this topic, and what is the state of arts and aging research, and what do I think is needed to go forward, and finally I'll just briefly touch on the Community Voices study that I've been conducting. So why now? Well, you probably all are aware that we are in an unprecedented point in history in the United States, in that the growth in both the number and proportion of older adults will be the largest that we've seen, as you can see on the x-axis, that's starting in 1900. And this represents the population age 65 and older. And where that red line crosses that blue line, the blue bars there, that suggests that the proportion of older adults will actually be the highest, estimating at 20% in the future. Also, the older adults in the United States will also be more diverse, and I think this is one of the compelling issues that drives me in my research to think about more novel ways that we can reach older adults in the community. And so how can the arts actually help improve the experience of aging? And we already know there's this immediate need for developing novel ways for older adults to remain active, independent, and engaged. And what is the potential of the participatory arts? Well, we know from research already that we can address issues such as well-being and think about quality of life and vitality and joy. There are also some studies suggesting that participating in the arts may help improve brain health. We could think about independence and community engagement, so not only keeping an older adult engaged in the community, but also improving the health of a community in and of itself. And the concept of lifelong learning, which tends to be a topic that comes up in a lot of the White House conferences on aging, and age-friendly community design so that access to the arts is there, and also potentially management of chronic illness. And I think a lot of these areas are new, which I'll emphasize today. So why do I think that the arts-based research in particular is important? Well, first of all, the focus on using the arts to help promote active aging is actually a relatively new endeavor. And when I talk about the arts in this context, I'm thinking about participatory arts. So we have theater, drama, we have music activities, there's visual art, dance, creative writing, photography, etc. And millions of dollars are spent in the United States annually on delivering these arts programs for older adults, but we really don't know very much about the scientific basis for these types of programs and their benefits. So we need to learn which programs could help improve health and well-being, how the programs work, and actually which will have the biggest impact. And I think this interest in doing more research you see will increase in the future. And I think we have a general hypothesis that participating in these types of creative arts lead to better health, but we actually don't know how this happens. And this is one of the research questions that I've been exploring in the last several years. One other point I wanted to make is that we don't have very many good theoretical models like those that we have for physical activity that can help inform the hypotheses about what might be the mechanisms. And we don't have these yet for the arts. And part of the reason is you might expect that we don't have a lot of good animal models, for one. We don't see a lot of mice singing in choirs. But that's just one aspect. And most recently, in 2012 in Washington, D.C., we had a wonderful convening of both the National Institute of Health, the National Endowment for the Arts, and the National Academy of Sciences all came together to think about what are the research gaps and opportunities for exploring this relationship between arts and health. And there was a white paper that was produced that you can read on the National Endowment for the Arts workshop, website rather. And then recently in May of 2015, there was a summit on creative aging in America. And this, again, was a collaboration between the National Endowment for Arts and the National Center for Creative Aging. And there was a special issue published on the White House Conference on Aging, in particular, thinking about what is the potential of the creative arts for older adults. And as we talk about humanizing the experience of aging, even more, I think this is one of the ways that we can think about issues that are important, such as quality of life and vitality, and tapping into some of these areas that often are left behind in this biomedical models of aging that we have. The 3 tracks, we spent a whole day talking about lifelong learning in the arts, health and wellness, and age-friendly community design. So what is the state of this area called arts and aging research? And today I just want to talk about the participatory arts, and this is really not focused on the creative arts therapies, but more of participatory arts for community dwelling older adults, so healthier aging. And of all over 100 studies that were found in the literature, only 31 intervention studies really met the criteria for being relatively scientifically rigorous. And this review was published by Tony Noyce in The Gerontologist. And I think one thing you can see is that the studies are relatively recent, and there's been an increase in interest since 2000. So this is a really new area, and I'm excited to be on the cutting edge of this and thinking about this. And just to give you a sense for the type of research findings that came from this article and this review, and again, these are participatory arts, both with music, theater, creative writing, dance, etc. So there are some themes that there might be some improvements in cognition, also in quality of life and emotional well-being, but as you might expect, as different studies use different research designs, there also are some studies that have found null results in these areas. So what do I see are the gaps? So as I alluded to, the number of studies is quite small on any one art form, and then collectively there's really not that many studies out there. And what has been a common theme among the scientists is that many of these studies actually lack the scientific rigor that is needed to compete with other types of studies in the biomedical field. As I mentioned, there are very few theoretical models that guide the research, and the measures of the impact of the arts are not comprehensive. And I don't think it's just as simple as taking our traditional clinical outcomes and applying those to the creative arts. I think we need to interrogate the space of what does creativity mean when somebody is an older adult, and how might we measure something like creativity, and the joy or the enlightenment that might come from embarking in that type of a process. And importantly, the funding for this research has been quite limited, which has contributed, I think, to less support for arts programs in the community. So it's an issue also of access. So I think I love the history of science, and I like to think about what were some of the significant events in arts and aging that have occurred. And you can see on the public sector that is back in 1965 was the Older Americans Act, and in 1974 was when the National Institute of Aging was founded. But shortly after that, the National Endowment for the Arts actually took an interest in thinking about the arts, humanities, and older adults. And these convenings were repeated both in 1995 and in 2013, and recently as 2015 with the White House Conference on Aging. So it's interesting when you compare this to some of the public or private efforts that have occurred, both with the Center for Aging, Health, and Humanities at George Washington University and the National Guild, taking on an aging and arts and aging toolkit. So there's a lot of space here to think about contributing with some support. And I might say we just received a contract from the National Endowment for the Arts here at IHA to write a research or write a manual that will talk about how to do research, arts-based research across the lifespan. So we're really excited that there is support in that sector. So what's needed going forward? Well, as I alluded to, we really need to increase the amount of studies that are available and also improve the scientific rigor. And I think UCSF is hopefully going to be leading that effort. In the near future, we've been talking with a few foundations who might be interested in helping seed or potentially put together a collaboratory of foundations that would be interested in this. We're also interested in examining ways to help make the arts interventions more effective. We know so little about what makes them work, but I think there's a potential to improve upon that. And also developing novel ways to measure the impact of the arts on older adults. And we see this, to be able to do this is actually bringing arts practitioners from our community in with the researchers and start to really think about, what are the potential benefits that might happen when we bring in artists who want to talk about the science and scientists who want to talk about the art, the creative arts. And here at UCSF, we actually have a number of faculty, close to 10, who are already engaged in doing arts and arts-based research. So I think we can pull together our colleagues across the campus and also at IHA as a leader to do this. As I mentioned, identifying the mechanisms by which the arts exert their effects is very important, and I think this is an advantage we have being at a biomedical campus. We could potentially think about some creative ways to study the effect on physiology. So I'll just conclude with a current study that Wendy mentioned. It's called the Community of Voices Study that was funded by the National Institute on Aging back in 2012 with the goal of examining whether or not community choirs are a novel way to promote healthy aging and independence of older adults. And I can't believe we're almost to the end of the study. But it's been a wonderful three-way partnership here in San Francisco between UCSF, the Department of Aging and Adult Services, who's been very supportive, and the Community Music Center, which is a 90-year-old nonprofit who delivers community music programs to the community. And our aims are to evaluate the effect of the one-year community choir program on health and well-being, and also evaluate the cost and cost-effectiveness. And Dorothy, when we talked about infusing the cost-effectiveness analyses and lots of studies through the work with Wendy, this is how we do it. These are the 12 senior centers that are participating in the study, all supported by Administration on Aging. They've been a fabulous collaborator in this project. And we're implementing a cluster randomized controlled trial where each senior center will be randomly assigned to either start the choir intervention program immediately or wait 6 months and then begin. So we have completed our baseline enrollment, and I'm happy to say that we have almost 400 participants ranging in age from 60 to 93. 2/3 of our sample come from non-diverse backgrounds, and want to mention also that we were able to do the study assessments either in English or Spanish, and the mean age is about 70, about 3/4 women, 25% have a high school education or less, and about 1/4, again, report that their health is fair or poor. So we feel like we were able to reach a diverse sample here in San Francisco, and we're really happy with our enrollment. So rather than talking more about the study, I think it's much easier to just show you. Here's a wonderful clip that was a video story that was put together by a UC Berkeley student, and I'll just let the participants tell you what they're doing.
La mayoría vivimos solos y entonces necesitamos hablar con alguien, compartir.
Me siento feliz, te desahogo, como que estoy desahogando, se me olvida todo.
Cuando empecé estaba un poco afectado de salud, sentía pues sin interés.
The Community of Voices is a study that UCSF is going to be doing for the next 5 years. 12 choirs for a duration of 1 year each. This one is the first choir that started the whole project. The concept is they want to be able to prove scientifically that music and singing is good for the health of seniors.
Looking primarily at 3 areas related to the choir and singing. The first one is looking at how the singing in a choir might impact your cognitive health. So does this help your memory and your attention? The second area focuses more on motor function. And in particular, we're interested in kind of lower body strength to see if singing in a choir on a weekly basis can help improve physical function. And finally, the big area is more psychosocial factors. As you can imagine, singing in a choir might be able to help address issues such as loneliness or depressive symptoms.
Me siento alegre, me siento como importante, según yo.
Este coro nos ha cambiado muchísimo, que nos olvida el dolor y cantamos y nos emocionamos.
Mi canción favorita es la de Colores, la Sandunga, casi todas.
Creo que lo haré hasta que ya no pueda caminar o cantar.
Estar ahí enfrente del público nos agrada y agradecemos que, como quiera que cantamos, nos aplauden.
Thank you so much.
All right, that's it. That's the end of my presentation. Thank you, everybody.
We were thrilled when Dr. Fernando Torres-Gil accepted the invitation to be our keynote speaker today. Dr. Torres-Gil is a perfect fit for our celebration. His stellar career includes the academic, professional, and policy arenas. His work in the fields of aging, long-term care, disability, entitlement reform, and the politics of aging is world-renowned and is well known to many of us in this room. Dr. Torres-Gil was born and raised in Salinas and earned an MSW and a PhD in social planning and research from Brandeis University. Dr. Torres-Gil is professor of social welfare and public policy at UCLA, where he's director of the Center for Policy Research on Aging, and has also been acting dean of the School of Public Affairs and chair of the Department of Social Welfare. He's also adjunct professor of gerontology at USC. He has authored 6 books and over 100 publications. He's been elected as a member of the National Academy of Public Administration, a fellow of the Gerontological Society of America, and a member of the National Academy of Social Insurance. His long list of honors includes, most recently, the Social Justice Award from the Gray Panthers. Dr. Torres-Gil has been appointed not once, not twice, but 3 times by the president, actually 3 different presidents, to important public roles. He was appointed by Jimmy Carter to the Federal Council on Aging, by Bill Clinton as the first U.S. Assistant Secretary on Aging in the Department of Health and Human Services, and by President Obama as the Vice Chair of the National Council on Disability. He also was a White House Fellow under then Department of Health, Education, and Welfare Secretary Joseph Califano. He managed the Administration on Aging. He organized the 1995 White House Conference on Aging, and he served as staff director of the U.S. Select Committee on Aging. He's also been involved at the state and local level and serves on a number of nonprofit foundations. I could tell you more. The list is very, very long, but I don't want to cut in any more to Fernando's time. So it gives me great pleasure to welcome you today, Fernando. Thank you for joining us.
Thank you, Dr. Max. Thank you, Wendy, for inviting me, for your leadership of the Institute on Health and Aging, and to you and your staff for putting up with me and my complicated logistics to get here. I truly appreciate being here. This was not only an easy invitation to accept, but I was thrilled to be invited, but a little nervous because I knew I would be surrounded by the real stars of the field. And if I have any complaint and if I have any disagreement with this great program, somebody mistakenly listed me as a star in the field of aging. I'd like to think that I'm still young enough that I have to prove myself so that it gives me an incentive, motivation to stay hungry and work hard. But in all sincerity, it's just a real thrill to be here with all of you, to celebrate your 30th anniversary, to honor all those who have made this ORU, as we know it in the UC system, the Big C, to make this institute such a success over the last 30 years, and to be at what I consider kind of like a family reunion. This is a family reunion, an extended family of mentors and visionaries and friends and colleagues and allies and, yes, co-conspirators. I almost hesitate to start, but I have to name a few of those names. Certainly, thank you so much, Carol, for all you've done, not just founding this institute, but being my friend, my co-conspirator, and all the great adventures we've had, and aging together through the field. Thank you so much, and he reminded me we were at the Haller School for a period of time together. And here we are in California, still in the fight. And certainly to Dr. Dorothy Rice and all she's done and her leadership, she reminded me there's this guy that's on my faculty and we see each other all the time. He's actually one of the stars at UCLA. And she just reminded me, it's her son, Tom Rice, who's my faculty colleague. And my only response was, I just saw you and Tom Rice as two different personalities and individuals, but they are biologically connected as mom and son. But, and certainly to the others, Patrick, where are you? We came to know each other when we were on the board of ASA, and he was giving me assurance that yes, you can retire and there's life after retirement. David, we have the regional director for AOA. Raise your hand over there. From the Administration on Aging. David is here, another longtime friend, and there will be others that I know. And then I do have to mention the future leaders of the field. Brooke, who's going to put it all together after I'm done and make this all sound coherent. So, I'm done. Thank you very much. It was good to be here. I do have to sing for my meal. And I was asked to reflect on the past, present, and future. We have heard so much detail and documentation and proof that the Institute on Health and Aging has been extraordinarily successful. And to the Dean, you've got a good thing going here, supported with resources and FTEs and hard money. I used to be a dean and I was always being hit by my faculty for those things. Now I'm just a professor so I can give the dean a bad time and so. But you know you've got an extraordinarily successful ORU and I know you believe in it, and so all of this richly deserved. If I had any words to kind of summarize all this documentation and proof and concrete accomplishments, what you have done is a couple of adverbs and verbs. You have been thought leaders in the field, helping us to understand and envision where we should be going. You have been visionaries, sorting out what ought to be, how life should be, what the quality of aging can be, that we're not quite there yet. Certainly you've been doing cutting-edge research and intellectual and theoretical research that have brought not just luster and credibility to UCSF and the UC system, but have given gravitas to the field and those who are advocates and pushing for social change. You've also been, in your own way, community advocates, never forgetting that we're in this business to help real people who are our constituents, our families, and our friends. And if I can go forward and even say that you have been the moral authority for how we should do things with compassion and with integrity and with transparency. All of this and these words and these phrases apply to the Institute of Health and Aging. So a round of applause to all of you. Congratulations. And that has been the past. And your impact on policy, I can testify from the various political and public positions that I've had in my long career, the impact has been real. I've taken your ideas. I've been inspired by your ideas. The Beltway knows about what you do. Sacramento certainly knows about what you do. So you have dealt with the big picture, the big questions, and the big policy that is so needed in this country. And so you can take the time to revel in the moment, to pat yourself in the back. And thank you for letting me be here to reinforce what you already know. You've done great things. Now, what about today? If anything I've learned in Washington, my many years in politics, you're only good as what you're doing now. And your value to continue has to be, what now? How do we impact the present? And how do we prepare for the future? And in my short time, I'll try to just give my thoughts and observations. Although I have to admit that first, you've been a great audience. It's now almost 10 minutes to 4. And if there's something else I've learned, the two most difficult places to speak and to keep an audience attention is speaking at a senior citizen center during noontime and speaking to faculty around 3:30, 4:30, and not to even mention trying to keep students' attention at this hour. So to kind of liven it up, and thank you for this great presentation on art. And now I'd like to add some humor. Are we allowed to tell jokes in this very prestigious location? Oh, it is a good thing to be. And I know that this is San Francisco, and I'll tell you in a moment that this is also one of my homes. So I know how San Francisco is. They're very PC. You know what PC means, pathetically correct. I mean, everything has to be just appropriate. Am I allowed to be PIC? PIC? I only can tell one joke halfway decent. My wife says I'm a joke destroyer. But now I'm going to talk about the present, the potentially bad news, but the good news that you can play a part in. And this is about two gentlemen in a nursing home. And as we know about long-term care facilities, gender differentials, longevity, etc., there'll be more females than males in the facility. So there's these two guys, we'll call them Patrick and Sean. I'm also a Boston Red Sox fan. And they were the only guys in this facility with females, so they hung out. They spent their time debating and watching baseball. And they're only concerned about the end of life and passing away, was whether or not they would find baseball in heaven. So they made this agreement, this interagency agreement, that whoever passed away first would somehow get back to the other and answer that all-important public policy question: is there baseball in heaven? Patrick passes away first. As you can imagine, Sean's grieving, missing him. One night, Sean is woken. He hears Patrick's voice up there saying, Sean, wake up, wake up. But you're supposed to be dead. Never mind, wake up. I got the answer to our question. And it's good news and it's bad news. The good news is there is baseball in heaven. And it's a hell of a team. The bad news, Sean, is you're pitching tomorrow morning. You have to think about it. Unless you're a gerontologist, you'll get it real quick. By the way, I tried to share that joke when I was on the IOM end-of-life committee. It did not go over well. They had no humor, although Bernie Lowe, who was on our committee, he was a pretty funny guy, but the committee had no humor. But in either event, let me talk about some of the not so good news and some of the challenges, and then end up with the good news and the opportunities in the field of aging that you have helped to create. First, of course, I should just kind of let you know where I'm coming from, and many of you know me and know my past, and you've seen the made-for-TV home movie, and oh, there isn't one yet, one of these days. But if I was to summarize my own personal history that informs my research, my professional activities, my public service, and now at this ripe old age of 67, how I view that next stage in my career, I can just summarize it by saying I've been a poster boy. And I am a poster boy. As a child, I was the poster boy for the March of Dimes, having contracted polio at 6 months of age, and through the wonderful pro bono medical care and generosity of Shriners Hospital, which had been located on 19th Avenue for many years. After from 2 to 16 years at Shriners, they gave me back my freedom and my mobility. Then over the years, I've been a poster boy for aging with a disability, and what it means to live life and cope and move forward. Now, I hope I'm a poster boy for falls prevention, and avoiding those vagaries and vicissitudes of growing older and having some kind of chronic condition. I hope I can now become a poster boy for re-envisioning aging and how all of us can plan for it. So I would kind of summarize my background in that way. I've also, of course, had the great good fortune to move into the field of gerontology when it was relatively young. And Carol, I'm going to also do a true confession here. In 1971, I had left California for the Heller School, and as a good graduate student, always looking for a chance to make a little money, and Professor Jim Schultz came to me and said, Fernando, would you like to make a little money working at a conference? Sure, of course. What is it? It's this conference in Washington, D.C. We would like you to be part of a student evaluation team. It was the 1971 White House Conference on Aging. So of course, I knew nothing about dermatology, or they could barely pronounce it, but a chance to go to Washington, D.C., be part of this conference. I went, I was mesmerized, I was captivated, and I got really involved with the minority advocates and Maggie, who were protesting the 1971 White House Conference on Aging, because it was Beltway oriented, it was all white, no sensitivity to diversity, women, LGBT, et cetera, et cetera. And there was this really weird, strange, loud, obnoxious old lady that was telling all of us, we're gonna go march on the White House. That was Maggie Q. That's how I met her. So we all followed the Pied Piper. And of course, I didn't realize that at the age of 21, 22, I was meeting the giants of the field. I got involved with the minority aging groups, et cetera, et cetera. And then when I went back to the Heller School, I did not tell Professor Schultz that I violated the fundamentals of objective research, because I was involved in the organizing until he found out in the final program that I was listed as a delegate to the 1971 White House Conference on Aging from Massachusetts, and so I've been living that down ever since. But that was my entry to the field. It's been a wonderful ride, and now what I'd like to do is kind of share my thoughts on where are we today. And I've been thinking, how can I summarize it? And I thought I would leave five themes, without giving a whole lot of detail going in depth, but just to kind of serve as teasers for where I think we're at, where you can think about how it fits in, and of course disagree or have different points of view. The first theme is, we in the field have become victims of our own success. Victims of our own success. That is, the many pioneers in this room became pioneers when the field of gerontology and geriatrics was little known, no real prestige or glamour, and essentially we were voices in the wilderness and true believers. It was a wonderful time to be in the field, just a core group of individuals that cared and committed their intelligence, their energies, their careers to this field. Today, gerontology is trendy. Some might say it's even sexy, and it's mainstream. Everyone wants to get into this. Sadly, a number of those that are now interested in this field are interested not for the reasons that we have been, you have been, but more for reasons of taking advantage of this growing constituency. Sell products, market new drugs, find ways to take advantage of this large constituency. And in a free enterprise market society, that's not altogether bad. That's not altogether bad. But now we have entrepreneurs in the field. And what disturbs me is many times these entrepreneurs have little interest in understanding the fundamentals of gerontology and geriatrics. It's really, how can I capture that market? At the 2015 White House Conference on Aging, one of the speakers was this 30-something-year-old entrepreneur from Silicon Valley who came up with this new app that he was promoting there at the White House that would enable families to find people to take care of their elders, which was actually a pretty good idea, except he presented it as if he had discovered it and his app was going to save the world. and solve caregiving and long-term care. And then, of course, we ask ourselves, wait a minute, so where has the aging network been all these years? So the point here is we become victims of our own success in a way that many others now want to be in this field, how we can find ways to gerontologize and maintain the integrity, the honesty, the transparency, and ultimately about serving others is a challenge that remains. Second theme, we have a host of slow motion crises occurring. Slow motion crises, little volcanoes that have not yet blown up. Whether it's issues of growing chronic conditions, whether it's early onset diabetes and dementias, whether it's our inability to develop a comprehensive home and community-based system of services and support for family and caregivers, there are many not so good things happening that at some point will only grow in severity and urgency. When and how we get ahead of that remains to be seen. But we all know some of the problems and growing issues in the field of aging and those that we serve. The third theme is what I call the big D as in denial. Much of the public, if not most of the public, is still in the big D stage. I will never get old. I will never need help. I will never be dependent. I like the way somebody phrased it, live to be 90 and then die quickly at night without any pain and everything would be fine. But the theme here is that the big D will soon give way to a new reality. Will give way to a new reality with 78 million plus baby boomers who in this year are now all 50 years of age and over. Those 78 plus million of my cohort, or some of you, your cohort, at some point they're going to face the realities of what it means to live a long time. And as Dr. Arthur Fleming always referred to, the vicissitudes of aging. Of course, one of the good news, and you've played a big role, is that we push back those vagaries further back. We do live longer, relatively healthier, and with fewer disabilities as we get older. But sooner or later, it catches up to us. So what happens when, excuse the language, all my baby boomer cohorts wake up someday and say, oh shit, I'm old and I'm having these problems. Then what? So we have lots of work to plan for. The fourth theme is that we are in the midst of great debates and conflicts about the evolving social crises. And in that way, I look again to Carol for her social construction of what a crisis is and is not. The Aging Enterprise was one of the first to critique how we were becoming as a field and should not be as a field. But in the last 30 years, and especially in the last 10 years, we have come to a point where there is no consensus about who is responsible for whom. Who is responsible for whom? The crises of the 1930s and 1940s, our great-grandparents, grandparents, created a public unanimity that a social contract has to include that government and society is responsible for individuals, while individuals will accept that they will be responsible to be good citizens. And by that was meant that the federal government would ensure a measure of a safety net. We now know it as Social Security, Medicare, Medicaid, SSI, unemployment insurance, labor union agreements. I mean, a whole host of things happened from the 40s, especially through the 60s and 70s. They gave us actually a pretty robust safety net. And when I say there was an agreement, I'm talking about just two types of people that matter in politics: voters and taxpayers. Voters and taxpayers. If you don't vote, you don't pay taxes, you're not really part of that electorate. That might be a little harsh, which explains some of the politics of aging later. But that social contract, where government would step in, where you needed help, but you had certain responsibilities to prepare, has begun to eviscerate, if not disappear altogether. And I always like to tell my students, especially the millennials at UCLA, once upon a time, in a place far, far away, there was a cohort that believed that we should help others. And that cohort, which is the greatest generation, actually believed and were willing to pay taxes to fund things like highways, public education, the GI Bill, even if they as individuals would not get a return on their investment. But even more wild about that cohort, they actually trusted government and thought that government could do good. Isn't that wild? Once upon a time, the public, the taxpayers and the voters believed that way. The great debate now is to what extent should we move towards individual responsibility, where you're responsible to prepare for your financial and retirement security, prepare for your longevity, prepare to do caregiving with your own resources. The election of Paul Ryan as Speaker of the House of Representatives gives you a visual template of how he defines the social contract. Privatizing Social Security, vouchers for Medicare, and shifting Medicaid, Medi-Cal to a block grant and leaving it up to the states. And so you can get a sense of that debate. And by the way, those views, whether they're considered right or left or middle, are not bad. They're sincere. It's about debates, ultimately, who's responsible for whom and in what manner. And if there's balkanization in the Congress, it's because there's balkanization in the public that can't agree which way we should go. And then the last theme I will raise is that the real demographic shocks are yet to arrive. The real demographic transition of the United States of America are underway and have not yet come to fruition. And the times that I use, the timelines, is 2030 and 2050. 2030 and 2050. That's the full fruition of the demographic changes that are occurring at the moment. And in this case, I'll just pick two variables, race and age. Race and age. We now know, and it was shown, we're experts in the aging of the population. By 2029, if my math is correct, every baby boomer will be 65 years of age and over. Think about that. 78 million plus members of my cohort, all 65 years of age and over. I sometimes wonder, do I really want to be with them in my long-term care facility? Because we could be a pretty ornery, entitled generation. But that's the first thing. 2050, the United States of America will look like California. The United States of America will look like California. That is to say, the United States will become majority minority. We know that in California, in the Bay Area, in Southern California, throughout the state, we are now majority minority. And that demographic change of what I call the nexus of aging and diversity will have profound impact in ways we don't yet know. And how we come together with age and race and ethnicity and diversity is something that I would encourage you to give more attention to. You are already in terms of health-related issues, but we need to ask ourselves, what does it mean in terms of the electorate, in terms of allocation of resources? What does it mean for perhaps bringing back a potential social contract? Now, that's today, my 6 themes. The future, as I wind down. Where do I think things will go? Now, I hope to have a couple of good news. But first, I have to do the bad news. And if we ask what will define aging by 2030 to 2050, which I think is a good time frame, benchmark, for your next 30 years. It's 2015 right now. You can start plotting out your research agenda between now and 2030, and then between 2030 and 2050, with the full support of your dean. And I have 1, 2, 3, 4, 5, 6, 7, 8 issues to consider for the future. Very quick, I won't elaborate. The first, we sadly know too much about the social and economic disparities we are witnessing right now will play out in the aging of the population. And so we can sort out all the tensions, the issues, and that will mean a whole new and increasing group of vulnerable and poor elders, However you use it, whether you use a new measure index developed at UCLA with Steve Wallace, or the current one that's being used by the federal government, whichever one you use, greater poverty in the elderly. We're now getting some clues that the dramatic success of the 1930s to the 1970s with dramatic drop in poverty among the elderly is beginning to go like this. And we can just assume it may continue to go back up. That's the first thing. The second, retirement and pension security and insecurity. I think nothing will be more visceral for the next generation of elders than very simply, will I have enough money to live on? And for those of us who are benefiting from the last true socialist system in America, which is the University of California public benefits. You know, when I tell this to my students, they get upset. Do you realize, young man, young student at UCLA or Berkeley, wherever, that when I retire as a UC professor, I get a defined benefit plan, a guaranteed pension for the rest of my life? Isn't that amazing? Oh, I get retiree health care coverage. Oh, and I've been allowed to contribute to a defined contribution plan. When you think about that, we are the last cohort that will have that kind of privileged status, as I mentioned to somebody earlier, this last grand bargain between Napolitano, the president of the university, the governor and legislature, is going to begin to end that privileged set of benefits starting in 2016 for new faculty hires that are going to see a cap on their defined benefit plan and increasingly relying more on defined contributions. And those of us that are chairing search committees, you know, I'm not sure I want to tell a potential recruits that if we don't hire you before July 1, 2016, you're going to be in a new system, which won't be as lucrative as the one we have now. But even then, we're still fortunate. Most of the public doesn't have that, very simply. Most of the public doesn't have that. And that creates a whole other set of insecurities. Third, generational relations, or generational interrelationships, or generational tensions. And it's real. And we really have to note that in this long life, long span, longevity, we now have a number of cohorts or generations that thinks somewhat differently, whether it was the greatest generation, the baby boomer generation X, the millennials, and the one now K through 12, which Generation Z, I think is what they're calling them. The fact is, they do have very different views about the social contract, and about Social Security and Medicare, and about things like government workers getting pensions. I mean, and their votes will matter. So for me, it's how do we educate and inform the younger cohorts in a way that they can appreciate what the pioneers here have done to give us what we have, and hopefully, and now I reveal my ideological bias, maintain and expand the great things that came out of the previous century. But generational relations will matter. The next one I've already made reference to, multiculturalism. I won't go into that. I can if you want to ask me questions. The next one is the feminization of longevity. The feminization of longevity. Many of you here have been the pioneers to lay out not just the gender differential, but how we have treated men and women and those of different sexual orientations differently and not altogether fairly. And so in the future aging, we, of course, must give greater attention to the differences in how individuals identify and view themselves as human beings. Then, of course, we can't miss the issues of caregiving and long-term care. And here I'm informed by my current roles on the Institute of Medicine. I'm co-chairing with Terry Fulmer from the Hartford Foundation, IOM's National Forum on Aging, Disability. I call it long-term care, they call it independence. But it's trying to find a way to work with the federal government and the Congress to try to move a little further ahead on our difficulties trying to accept that we absolutely need a comprehensive universal system of home and community-based supports. I won't get into issues of the PASS Act and other things of that nature, but the caregiving crisis is real. It's one of those slow motion issues, and everyone has a story to tell about caregiving. And then the last couple, my favorite, the politics of aging. Who votes? Who doesn't? And what we are facing at the moment, we have an age-race stratification in California and the country. Very simply, but not simply, the majority of those that actually vote are over 50, English-speaking, white. The majority of the population under 50 is now ethnic minority immigrant, non-English speaking, and they don't vote in proportion to their numbers. So we're facing this dichotomy for the next couple of years, and my good colleague Bob Brownstein from the National Journal speaks about this eloquently, as do some other colleagues like David Dowell-Myers from USC, Fred Lynch from Claremont Colleges. We have a tension where the voting is one group with a different set of public priorities, lower taxes, safety, protection of public benefits, and another segment that is about the American dream, good jobs, employment, education, training, good schools, investing in my kids. And so we have that dichotomy in the electorate, and it's playing itself out. It kind of helps explain the Tea Party in part and Donald Trump. But don't laugh, he could be president, you never know. This is a great country where we teach young people anyone could be president. Although I do have to say, when I was a student at San Jose State, we had a governor who we detested for a lot of reasons. And then he announced he was running for president. And we went all over the place saying, don't worry, it'll never happen. He's a B-screen actor. He can't speak. He's a dummy, and he doesn't know anything. He could never be president. Ronald Reagan became a very important president. So anything can happen in our democracy. But the politics of aging. And then one of my other roles is as a board member of AARP. And AARP, say what you will, they are a $1.4 billion corporation with tremendous clout to do good. And among other things, we're in the midst of trying to reimagine aging, or at least find a way to work with those who will live a long life, to find ways to, in a positive way, plan ahead about different roles in life and how they can reimagine what it means to have that longer lifespan, and how to prepare for those potential vagaries as well as opportunities. But regardless, we are all going to see a redefinition of what it means to be older. And the fact is, and this gets, I think, to Carol, but also Bernice Newgarden, another one of my mentors. When I was on the Federal Council on Aging in the late 70s, we had big arguments because she felt that age was not an appropriate criteria for public benefits. My response, how can you say that our senior citizens, we must take care of them, and they're the deserving poor, and if they're 65 and over, they're all good, they're all saints, and they all must be taken care of. Our life was so innocent back then. And she would tell me, Fernando, just because you're over 65 doesn't mean you're all the same and you all have the same needs. Duh, now I understand it. So we have to address the issue in this redefinition. Is age really an appropriate criteria for age-based benefits? And should we move towards something else like ADLs or functional ability or some other criteria? Now that's, please don't quote me on this because that's anathema to the president and to AARP. But as a professor, as an egghead, I can kind of lay out, what if we considered this option or that option? But redefining age will be important. And then the last thing that I'd like to really pose to especially progressive liberal crowds, as we age and become multicultural, as we try to do the research and the policy analysis and the scholarship to prepare us for the realities of this new aging, let us not forget that we're part of a great country, part of a great nation. And with our added lifespan, we're going to grow old and live longer in this great country, the United States of America. Therefore, we have to pay attention to other issues as well. The environment, obviously, global warming, national security, and the bad people out there that mean to do us harm, our relationships with the rest of the world, or as I like to pose this question, as we grow older, live longer between now and 2050, do we want the United States to remain a superpower? And if so, will we be one of several superpowers, whether it's China, India, Brazil, maybe Russia comes back? Or do we, as a society and as a nation, are we tired of being the global policeman and trying to run the world? And will we allow ourselves to become a second-tier nation, like a France or an England? What is it that we want for this country? And I pose that because it may be far afield from our disciplines, but ultimately our disciplines is not divorced from where we live and the nation we belong to. And what happens to the country in the next 20, 30 years has direct impact on the resources, what we do, and how we treat this more diverse population. And then certainly one of my other main areas, as I'm at this age, in some respects, I'm starting to move away from aging. And it's not giving up gerontology or geriatrics, which will always be my passion. But I increasingly spend more time on issues of young people, and finding ways to invest in the next generation of young people that'll be heavily diverse. And as many of us know, that young people will someday be, hopefully, old people. And I think there's a significant correlation between starting off life as a poor, unhealthy, disadvantaged young person and becoming a poor, unhealthy, disadvantaged older person. But as importantly, those young people will represent the future taxpayers of this nation, which also leads me to another rhetorical question I'd love to throw to my progressive friends. And who will fight our nation's wars? If we're going to have a viable nation and protect ourselves, we need those young people who will increasingly be immigrants and minorities. But I go afield. Let me end this way. You've had an illustrious past. We've been fortunate to grow up with the field. I've had a great career. I can only thank all of you and my mentors and professors and my colleagues and my co-conspirators, and of course, my family and friends and those that have enabled me as someone aging with a disability to stay involved. So I'm grateful, you're grateful. Today we have a pretty good idea what the challenges are. And of course, let's not forget the good things. We have the Affordable Care Act, for example. We've begun to shift more Medicaid dollars towards community-based care, the greater awareness of aging, greater support for what we do. So there's a lot of good things happening. But the future, as always, will give us many more challenges. But I believe that's the great opportunity for all of us, whether we're still working, semi-retired, pretending to be retired, to stay involved. And certainly I would end with just three bits of old man on the hill advice. Although I know I'm older because the family, the young people and neighbors all refer to me now as Don Fernando, which in the Latino community is an honorific title, but it means you're really, really old. But you at least learned something, we hope, and there's a little bit of wisdom that you can share. So allow me to be Don Fernando and simply say, as you have done so well here, honor those who have led, who have gave, and who have created. And again, kudos to all those that you've honored today. Secondly, let's bring in and nurture new talent. And there are young, I don't want to say it's about age per se, but bring in more into our field. And then lastly, let's not forget we're now in the new century, and it's a whole different world, and we have to adapt to this new century. But that's what makes it exciting. I hope these words have been useful and reflective and given you something to think about. Thank you very much, and I can open it up to a few questions. Thank you. Thank you. You're very kind. And Wendy, do you want to referee any questions? Any pushback? Oh, and speak loud so we can all hear you, please.
You mentioned the need for universal system of home community-based services. And we're going to say, my name is before, and I work in home community-based services in the village movement, and we're about 80% of the community. But you mentioned that the need for that universal system. What do you think the likelihood is that something will ever really be financed for people who don't qualify for publicly funded services and don't have the resources?
If I heard you right. Well, first, thank you for the work you do with the village movement. It's a great and proven approach to reciprocity and neighbors and families helping each other. So it's a great thing. But I think your question was, what's a real reality of, will we ever find new financing to expand a public system of home and community-based long-term care services and support? My pessimistic side says it's not going to happen now, it's not going to happen tomorrow. And but my hopeful, optimistic side says we have to still wait to get enough critical mass of individuals and families that are realizing they don't have private long-term care insurance. They don't qualify for Medi-Cal. The Older Americans Act and the Aging Network, which provides tremendous community-based services, has not increased to meet the growth of the population. That there are some great waiver programs in Medicaid and Medicare, but they're very limited. We have to recognize all these realities, and we're doing that at the Institute of Medicine. But the big hurdle is that we do not yet have a critical mass of members of Congress that have accepted that this is a national concern. And in part because the public hasn't risen up and said, this is my priority. And I think that will happen eventually. At least I'm hoping there'll be a social movement in that direction. But it's not today, it's not tomorrow. I've always felt that by the time we reach close to the mid-20s, 2022, 2023, when all members of the baby boomer cohort are dealing with the lack of those options and adequate support, that might give us the political clout. While we continue to work in that direction, there is no stomach right now for a new entitlement program or a Part F to Medicare. But again, that's because we haven't resolved the issue of should we have a social contract and what should it look like? But don't give up hope. Don't give up hope. We just got to keep pushing.
Yeah, I was going to speak a little bit about what you're looking at in regards to the needs of young people.
Oh, say that, the needs of young persons?
The needs of young people, yes.
Oh. You know, that, by the way, gives me hope right there. I may be way overgeneralizing from a random sample that has no power correlation, but I like these young millennials, those between roughly 19 and early 30s. At least we do these ongoing surveys of that college-age population across the country at UCLA. That cohort is starting to show certain traits unlike other cohorts. They're almost like their parents of the parents of the 1950s. They actually, first, they're clearly more inclusive and tolerant and comfortable with diversity. That's one, more than any other cohort. By the way, us baby boomers are getting real conservative. Matter of fact, and I shouldn't admit to this, but President Obama lost only one segment of the electorate, those 65 and over. And for AARP, when we were supporting the president on the Affordable Care Act, the one group that gave us the most difficult time were Medicare beneficiaries, because they thought they were giving up something. So we're kind of conservative that way. But the millennials are open, inclusive, tolerant. They also have a real strange trait. They like their parents. It appears they like to be with older persons, in part because many of them have had to return home after college because of the high student debt loads. But it seems to show, at least anecdotally, that they are appreciating they have family to fall back on. So what are their needs? Their needs are clearly going to, and I think they're going to be the catalyst, because right now they are moving into a world where there will be no defined benefit plans for them, period. Secondly, they don't trust government, and they don't think government will spend their taxes wisely, so they now have higher rates of savings in their 20s than any cohort before them. They're saving, and they're investing. Technology is their God. Technology is their God. And of course, it's given us amazing things that have made life fascinating. Whether it's made life happier is a different story, but it's made life fascinating and it's helped us in a lot of ways. So technology to them is what they think will save them. But if they don't mess up their health, they're going to live a long time. And so the question is, will they come to recognize that they too will have to prepare for longevity? Clearly that's not on their radar right now. But their needs right now is they just want to pay off their loan, try to afford a house. Many of them are thinking they have to leave California, it's too expensive. And so it's a fascinating generation. I like hanging out with them. I think I'll invite them to visit me in the long-term care facility. They're really cool.
Give us your forecast of what will happen in 50 years from now.
And this will be the last one. I will say, I believe, well before 50 years from now, I believe by 2030 we will finally have a single payer plan. And I'll tell you why. And by the way, I'm not that liberal. I'm actually conservative in a lot of ways, but I'll tell you why. Firstly, let's not forget, thank you, Dr. Rice. And this year, 2015, we're celebrating the 50th anniversary of Medicare and Medicaid, the 80th anniversary of Social Security. My numbers are bad. Something like that. The 50th... 80 years. 80 years. Yes. We're celebrating 50 years of the Older Americans Act. We're celebrating 25 years of the Americans with Disability Act. I mean, 2015 brings out that we've been, the real good news, we've done some great things in social policy. And it's brought tremendous benefits. The Affordable Care Act I've always seen as kind of a placeholder. And it's true, it really is a free market heritage foundation plan. That's what the Affordable Care Act, relying on the insurance sector with a lot of good features like no more pre-existing medical conditions, I mean, great thing. But essentially, it's a private sector insurance plan with no cost controls, or national regulation. And with a bargain with the devil, where the Congress and the White House had to agree that they would impose no discounts on the pharmaceutical companies, for Medicare, which is why pharmaceuticals are going up. And some of us, including Robert Binstock, who was the chairperson of my dissertation committee, felt that because of our particular ideology and characteristics of a nation, the Constitution, Declaration, Bill of Rights, I mean, we're not France, we're not Germany, we're not any other country, that we have to kind of muddle through these incremental steps before we conclude it's not working. And then when we conclude it's not working and the crisis has become more severe, then we're ready for a more fundamental or revolutionary change, which seems to be the only way these things happen. So my hope and expectation is within 5-10 years, the weaknesses and structural inadequacies of the Affordable Care Act, which we know what they are going to be so prevalent that then we have to ask, what next? And I think a single payer plan with an overlay of insurance companies still being there, with maybe even a 2 or 3 tier feature to it, as they now have in Great Britain and in Western Europe, I think that will have its chance again. But it cannot be, I don't want to say black and white. It can't be something we envision Canada has. It's got to still be based on our characteristics as a country. But I'm confident we'll get in that direction. I just hope it happens before my end of life approaches. So thank you.
Thank you very much. We heard it here first. So those of us who are around in 50 years can see what happens.
Okay. Well, now we've given Brooke Hollister the most difficult challenge of all to sort of tie this back to what our research agenda at IHA in the future might look like. Brooke is one of our homegrown success stories. She earned her PhD in sociology at UCSF with Carol Estes as her mentor. She joined our faculty at IHA in 2008 and has been working at the intersection of health and aging policy ever since. In 2012, she was selected as a Health and Aging Policy Fellow and spent the year in Washington working in the office of House Minority Leader Nancy Pelosi, working on health policy issues. So when she returned to UCSF, we created a position for her of health, whatever we're calling you now, Brooke, advisor on policy and dissemination. She prefers to be called policy wonk, but we give her a more formal title as well. Brooke's research focuses on aging health and social policy issues in the area of mental health, Alzheimer's disease, and health policy evaluation. So Brooke, tell us what we need to be doing now.
Wow. Well, good afternoon, everyone. Who am I to summarize a day like today? To be in the presence of such great leadership and I really consider Institute for Health and Aging a family. I've been here since I was 23 years old as a graduate student, so I have really grown into myself as an intellectual academic within IHA and those walls, and felt incredibly supported. I want to thank Fernando for such a great talk. One of the reasons I love hearing Fernando speak is he's such an eternal optimist. And after having spent a year in DC, I think I recognize how difficult that can be, especially since I was only there for 1 year and you had quite a longer tenure in and out of DC. Some of the things that I wanted to talk a little bit about today is just kind of what's on the political agenda and how does that work into the future of research at the Institute for Health and Aging, or what I hope to be the future of research at the Institute for Health and Aging. And I do recognize that I am, the one thing between you all and a glass of wine and some snacks outside, so I will try to keep it brief. But I am passionate about these things, so I hope I have a timer somewhere. One of the great things about being in DC in that position was that I was on the other side of the table from what I had experience in before, not so much as a researcher, but as an advocate. So being on the other side of the table, having people come in to talk to me, and usually Wendell, who was Nancy Pelosi's health policy and budget advisor, and to teach us about what they thought that we should know about policies, which was really informative for me, but probably kind of comical to Wendell since he'd been on the Hill for about 30 years at least. But it was an opportunity to learn from stakeholders, to understand what people's perspectives were coming in, and to really analyze communication strategies too, especially being in the minority in the House at that time, still. You rely a lot on communications. You're not necessarily setting the agenda, you're responding to an agenda that's set to put you at a disadvantage. And so communications is a really important piece of some of the things that I learned there. And in that capacity, I saw a lot of researchers come in and talk to us about their research and about their work and why they thought it was important and what they think that, thought that we should do about it. And some of them were much more effective than others. I think I learned quite a lot about how to talk about my own research during that time, and so I'm very pleased with my new policy guru, policy wonk position within IHA because I want to be able to give some of that back and to share that knowledge, which it's a different thing from writing a 20-page journal article to condensing it down into a 2-page policy brief with bullet points and policy recommendations. Researchers don't really like to make policy recommendations sometimes. It's almost like we feel dirty after. But to be able to do that succinctly is important. So, being in DC through that period, it was, government shutdowns, debt limits, ACA repeal 42 times. It was hard to come out with an optimistic edge, which is why I said I really appreciate Fernando's talks. Let me see. So back to some of the lessons I learned and what I definitely valued coming back to IHA, because I felt like I was coming back to a research institute that had the capacity to be able to make an impact policy-wise. We have, such a long, rich history of researchers who not only identify policy problems, but work with communities to be able to address those problems. Can convey messages in ways that are meaningful to policymakers and the general public. These are things that sometimes we'd have researchers come in and it wouldn't quite settle in the same way that it could have. So coming back to IHA and being around that again was really appreciated. IHA has a long history of policy-involved research or policy-driven research. Dorothy and Wendy, your work on tobacco research is incredibly impactful. It still has an impact today. I know that it's going to continue to grow, maybe into some conversations about the cost of e-cigarette use. That's my hope, at least. Pat Fox, where did Pat go? There he is. Pat and I worked together more after I graduated than while I was a student, but I started working with him around caregiving issues and Alzheimer's disease. Pat, and Wendy too, has a long history of developing kind of cost models of what it costs to provide care to somebody with Alzheimer's disease. That's a hugely impactful line of research. It's something more than just saying that caregivers are, deserving. It's more than just saying that people with dementia need caregivers. It's saying that this is going to cost us more money if we don't do it right. And doing it right means that you need to support caregivers. I still feel like we've had 30 years of research on that topic and really no policy uptake, so I can imagine some frustration, but some of the work that we've been doing recently around the duals demonstration is kind of interesting in that regard, so there's some optimism there. If you have a capitated payment system for health plans, they end up caring about how to save costs and how to keep people out of institutions. And so CalMedic Connect, the duals demonstration here in California, these private health plans are now responsible for the entire continuum of care, including long-term care. So if you say to them, well, if you provide a little bit of education to caregivers that are providing care for your members in the community, it can delay institutionalization. They all of a sudden want to pay attention. Something that we hadn't been able to get too much traction with in the political sector, but possibly in the private sector if we have capitated payments like this. Evaluation studies. Carol, your work on program evaluation, the state-specific Medicaid programs, I can't even imagine who all was on those, who all worked on those projects. Probably, a whole lot of Charlene and Bob and you, but we've continued that today. We have an evaluation of the duals demonstration here in California, which I was just referencing, but that's with Steve Kay, Carrie Graham, Charlene Harrington, Marion Liu. Within the Institute for Health and Aging, it's going to be evaluating the duals demonstration, which is a really big change. It's a big change for the health plans, who now are responsible for long-term care and behavioral health care. They're now responsible, for making sure that they fit within their capitated payment. And they have to start thinking outside of the box to meet their savings requirements. And so it's pretty innovative, and it's going to have a huge impact on beneficiaries. And so that evaluation, we're really looking forward to being a part of that, because we know it will hopefully have some impact on how the demonstrations move forward, and how they're replicated in other states as well. We heard a little bit about Barbara Koenig's research around and teams. Marcia's research around and the new efforts to try to take on the issue of ethics in physician aid in dying. Big legislative accomplishment this year, but what happens next and how is it implemented is a really, really important question. And so having researchers within IHA that can focus on that is of great benefit. So I want to talk a little bit about how Institute for Health and Aging has always taught me to be a really great community partner and to try to identify the people in the community that I would like to work with, and that could, help me learn about their issues and about the problems in the community, to make sure that the research was community-based and participatory, so that it had, better footing in the community, that it had better uptake and better sustainability. And many people within IHA do that. Julian Johnson, your work with the senior centers, you are completely embedded within the community and hearing from them through that work. Elena, you also are working with a lot of senior centers, also working through first responders to identify people with dementia who live alone in the community. Very difficult to serve population, very important population, to make sure that they're not falling through the cracks and that we're doing everything we can to provide a system of care for them. Pat, you left a legacy that we hope to continue, although working with the state of California has become a little bit more challenging. You established in me a recognition that not everything that I do needs to be paid for. That probably makes me work a lot harder than I should, but at the same time, there's a cost benefit to being involved in things like you did with writing the California State Plan for Dementia Care, or we both worked on the San Francisco Plan for Dementia Care, so working with the Department of Adult and Aging Services. There's several faculty within the Institute for Health and Aging who have done that. Jarman Ye is a graduate student. I don't know if Jarman's here. Yoo-hoo, there she is. She's been working with the San Francisco Age and Friendly Disabilities Task Force, who just had a big event a couple weeks ago. I know that's opened doors for her to working with the community and having an impact there. Since Pat and I worked on the citywide dementia plan, I've served on the Dementia Oversight Committee. Marion Liu, a new faculty member within IHA, is working with Adult Protective Services to try to see if we can design a better data system that collects information and can share information about elder abuse in California. Let's see, so one of the great tasks that I had in Washington, D.C. was to write memos. Memos to Leader Pelosi about any number of policy issues. The first memo I ever wrote took me 2 weeks, and by the time I was done was completely irrelevant. So you realize that you need to expedite the process a lot more. It also had citations, which to this day I'm terribly embarrassed about, because now that I know what memos are supposed to be, they're not supposed to be cited. There should be no bibliography. But they should be brief, really concise. It should be situated, not just in truth and reality, but situated within political constraints. It should be situated within the cultural environment. It should be situated within the people having the conversation. If you don't do that, then you're not going to be able to convey what it is that you need to be. So within IHA, I know that there's some exceptional faculty members who are really great at working outside of the general dissemination models. Sharon, your book, you wrote that New York Times op-ed piece. I think it had, last time I checked, about 175 comments, and which comments in and of themselves on op-ed pieces are really informative. So if you ever have some spare time, just reading through those comments is kind of fascinating. But making information accessible to practitioners, to lay public, to communities, to beneficiaries, to policymakers. It takes you almost have to put on a different hat or decide, that you're speaking to a completely different audience to be clear, concise, convincing, and consistent. Something about being an academic makes you think that you shouldn't say the same thing in the same way twice, that it goes completely against how you should be trying to communicate your policy messages. And so being consistent is really important. Since I came back, we've talked and actually written now 3 different policy briefs. They're on the front table out there, so this will be my parting remarks to you, and I'd love for you to look them over. The first one I worked on was on economic costs of smoking in California with Wendy and her team. Another one the second two that we've just released, interprofessional collaborations on Pulse, Jeff Newman, right over there. And Sherry Yamamoto is also in the audience up there. But they worked on efforts in California to expand the completion of PULSE forms, end-of-life decision-making forms. Really interesting findings that shows exactly how their research, helped contribute to the important changes that were made in California, and then what needs to happen next. Ben Scribner, who is also back in the back there, is a Carol Estes critical scholar and was also a NASI fellow over the summer and spent time working in DC with Altarum Institute on their family caregiver platform project. So back to some of the work that I've done with Pat, it's essentially to take all that data, all that research on how important caregivers are and how cost effective they are and what kinds of interventions you can do to make sure that they're well supported and avoiding excess utilization by the person that they're taking care of. Create a platform, a campaign platform. So Ben's work with Altarum has been to kind of trying to institutionalize the use of those caregiver statistics so that they could build those into political platforms coming into the presidential election season. I think I'm going to skip that. I think that moving forward, we at IHA need to recognize the legacy that we're a part of. We're a part of a very incredibly strong and powerful research institute that has a long tenured history and has had a lot of impact on policy to date. We need to make sure that we're not afraid to have a voice, to know that we can be an unbiased researcher and still have loudly voiced opinions. Maggie Kuhn used to say, and I never met her, but I feel like being a mentee of Carol's, it's kind of just a hierarchy. She's like the grandmother I never met. She would say, speak your mind even if your voice shakes. And so knowing that it can be incredibly daunting to share your knowledge with different audiences, but recognizing that it's really important that you do that still, even if your voice shakes. I think we were talking a little bit earlier, Fernando, you mentioned confronting denial. And I think that's going to be a big mission of IHA in the future. We need to be part of the source that is going to be confronting the denial of the population about what is in their future, what's going to happen, whether they have a secure future, and who's going to be taking care of them. And knowing that we have this legacy, knowing that we need to continue this legacy is important, but we also need to recognize and refuse to be the victims of our own success as well. So thank you very much. I think, Wendy, you had some concluding remarks also.
When I hear people like Brooke talk, it makes me feel very optimistic about our future, because this is kind of our newest generation of researchers coming forward with great ideas and insights. So I want to thank everyone for coming to our celebration today. I know there are some people that weren't able to come today, and we're very sorry they couldn't be here. One such person is Zena Mirsky, who is the recently retired Associate Dean for Administration in the School of Nursing. And a longtime friend of IHA. So if you'll indulge me, Zena sent me some comments that she feared jury duty would preclude her from delivering, and she kept me posted. And as I'm driving in this morning, apparently the bailiff said they were all going to be called. So I figured, well, I guess I'm going to have to read your remarks, Zena. So what Zena said was, I was involved in the establishment of the IHA as it grew from the center, housed in the Department of Social and Behavioral Sciences, and almost every step of the way as it grew to the first ORU in the School of Nursing. The first analyses of the growth and development focused mainly on finances and feasibility, and all proved successful. An assessment today would find the Institute for Health and Aging responsible for millions of dollars of revenue to the school and university, appointment of hundreds of outstanding researchers, and recruitment of many doctoral students to our various programs. Finances aside, the IHA has been the source of unlimited intellectual capital for our school and our campus. From the outset, the IHA has housed excellence in leadership and research team development. The many California and national policies which arose from the research in the IHA have been hallmarks of their work. We're all proud of we are proud of all who are and were involved. May they succeed for another 30 years and more. So thank you very much, Zena. So before we adjourn, just a couple of things. For those of you who weren't here earlier this afternoon, I want to again just mention the Patrick Fox Fund that we've established to honor Pat's legacy of research, education, and mentoring, and please consider contributing to that. And then I want to thank some of the people who I'm lucky enough to work with every single day and who really rose to the challenge of putting together this event. It takes a whole village to put on a session like this. We established 5 committees to pull everything together, and you can see the names of everyone on the back of the program. But there are a few people that I want to single out. Doug McCracken, our IT manager, who came down early to get everything working, and we'd be very lost without Doug, so we very much appreciate all that you've done and do for us, Doug. Regina Gudalunas, our business manager. Regina's always behind the scenes pulling together all the details, and this event was no exception. And it looks like Tina and Yana, who were sitting right there, are probably out setting up the food. Tina helped facilitate many of the details, including, as Fernando mentioned, arranging his visit to the point where she took a picture of the parking garage on her phone and sent it to him with arrows, here's where you can pull in and here's where you should park. So that was great. I hope that was helpful. And Yana, who did most of the publicity, she prepared the save the date, the program, all of the written documents for today, and patiently revised each of these documents at least 10 times as the rest of us read it and changed our mind and noticed little things that we'd missed the first 3 times. So she kept everything moving forward, and we're grateful. They're outside, and we can thank them in person. But without all the attention to detail and the help of all these people, a day like today could never have come together. And I also want to thank the Dean and the School of Nursing for their support always, and particularly for today's event. And David asked if he could have the last word. So, David, you get the last word.
Don't go away. What a warm, informative, and inspiring day. It was really a pleasure to have all of this come together. And the one person we haven't really fully thanked is Wendy Max, the leader. So again, thank you.